Hi, everyone. Thanks a lot, Munoh, for playing the jingle. I'm so sorry. I'm in the middle of a very important Congress meeting, the annual meeting of the American Society of Tropical Medicine and Hygiene. So a little bit distracted. I'm really thrilled, glad to have you all today for this another very important session. The session today is going to focus on a very important subject on breast cancer and the issues around the challenges and the challenges of breast cancer in Cameroon. And I think the patterns that we are seeing in Cameroon most likely also reflects the similar patterns that we have in other African countries. So I'm really thrilled that we have a specialist here to talk about some of those issues. I know Dr. Munoh sees thousands, or he has seen hundreds and thousands of patients in this area. So I hope the insight we will hopefully gain from this session will be very useful in terms of affecting policy changes and how we think about how we think about the subject of breast cancer in Cameroon. I'm here with Dr. Jean-Claude Kette. Dr. Kette, would you like to introduce yourself and say a few words?
All right. Yeah, good evening, everyone. Good evening, Brian, and also to Dr. Munoh, who is our formidable chair, but also the speaker for today. And I know this topic is very, very important for him, and not only important to him or for him, but also for most of us here, because my guess is that I'm sure one of us, one way or the other, have been affected by someone with, breast cancer, either close to us or as an acquaintance. So it's really a common problem. And I just look forward to the session tonight. And hopefully we are really going to have a good discussion and find some solutions, and then see how to follow up with those solutions to see that they really do work back home in Cameroon. Yeah, so thank you, Brian.
Yeah, thanks. I couldn't agree more, Dr. Kette. Really thrilled about this. I think this is a very significant problem in Cameroon that doesn't really get a lot of attention, and seeing the sort of epidemiological transition that we are going through in Cameroon and across the continent as well. I think that there's not a much better time to talk about some of these challenges and possibly the needs to build the kinds of capacities that are needed to address some of the deficits that we have. When I glance through the hall, I do see there are quite a few experts in different areas, and I just wanted to see if I could call in a few people, if you can if you could say a few words or comments on what your expectation, what your thoughts on the topic is, and what some of your expectations are, and how you see this issue of breast cancer really grossly in Cameroon. I would like to call Dr. Fegus Amde, if you could just introduce yourself and say a few words about this.
Well, good afternoon, fellow colleagues. In fact, I'm really anxious to listen, but we know, just like the moderator said, it's underestimated what's really happening. And most of the time, family members and friends, we only hear that they are at their terminal point. They've flown to Europe, they've flown to the United States. And I'm sure in the course of this, Dr. Munoh is going to tell you that it was never known, but they got to stage 4 already, and he's been struggling to manage them. They went back to Cameroon in their coffin. So I think talking about or educating us to be able to educate more family, friends, and patients would be far-reaching. Thank you.
Thanks a lot, Ambe, and it's great to see you again. And I totally agree with all the comments that you make. And it's very unfortunate that most of the diagnosis we see in Cameroon are occurring in the last stages where it's even more complicated to treat. So I think Dr. Munoh will probably talk about some of those challenges with late presentations and how we can resolve some of those, access to the kinds of diagnostic technologies that we need. I also wanted to call on Dr. Kengafak, if you don't mind. Dr. Kengafak.
Good evening, Brian. Good evening, everyone. I don't know if you can hear me clearly.
Yes, we can.
Okay, thank you. Thank you so much for calling upon me. It's a wonderful talk we're going to listen to, I'm sure of that. Over the years, Munoh has actually shown his passion for cancer through his different interventions whenever there was a talk. So there is no doubt that, cancer is a major problem. And I think maybe looking at the burden of disease, such as the frequency of cancer and the proportion of cancers that are determined early enough, we definitely have a problem on our hands. So I'm looking forward to hearing the talk and to seeing what proposed solutions there are, and the discussions that will follow will probably be fruitful in determining a way forward for our people in Cameroon. Thank you so much.
Yeah, thanks a lot, Kengafak, and also great appreciation for for your work in really shaping the epidemiological landscape in Africa from your station in South Africa. So really great appreciation, and we'll really welcome your insights during the Q&A later today as well. I would like to call really gracious to have Dr. Ivor Nzita in the house, and really thanks a lot. I know you see a lot of GI patients, but really curious about your insights and thoughts about the topic as a whole.
Thank you so much, Brian. I know it's been a while. I haven't been here, so I really appreciate the opportunity. If I came on today, it is primarily because I believe that the topic we are tackling today is a very crucial and important public health topic. Breast cancer is one of those cancers that we are fortunate enough to have tools that we can use to screen and detect folks before it becomes advanced disease. It's very important that our people understand that screening is primarily done on people who have no symptoms. And if there is any better time to diagnose a disease at the time where we can do anything to alter its course or its prognosis, then we must participate in screening. And given where we come from, we cannot deny the fact that if you don't have food to eat, sometimes it's difficult for you to be thinking about preventing something that may happen in 5 years down the road, because perhaps you will die from hunger before that problem comes in. But as you rightly pointed out, we are undergoing an epidemiological transition where we're gradually moving away from diseases related to poor hygiene, lack of food, and what I would generally call diseases of poverty into diseases of wealthiness. So we are living longer, so we are more likely to see diseases like cancers. So it is time for us as a people to begin to direct more resources and attention to preventive health. And if there is any one area where we can certainly make a lot of gains or inroads, it will be sensitizing our people on breast cancer screening. So Dr. Munoh, we all know him. We know his passion for cancer, and I have no doubt that the audience will be thrilled and we'll have all their questions, concerns addressed today by a very renowned expert and a man that I have a lot of respect for. So thank you very much, and I look forward to this session.
Yeah, thanks a lot, Dr. Ivor. It's really a great honor to have you again today. Before pass it over to Dr. Munoh, I would like to welcome a few words from Dr. David Oko, and I think we've had you in the town hall before, and also really been an expert in this area of individualized medicine and precision medicine and using novel genetic precision genetic markers technologies in his university at Emory University. So really would like to welcome a few words from you, Dr. David. Yeah, if you're speaking, you're muted. Oh, okay. I think he's probably on the phone. All right. Thanks. I think I will pass it on to Dr. Munoh. I think everyone knows who Dr. Munoh is. He's the he's the founder of the Cameroon Town Hall, this initiative that was birthed early in the COVID-19 pandemic to bring together healthcare experts to share their insights early on in the pandemic, and has really transitioned to address other public health issues affecting the health sector in Cameroon. And I think it has been very useful. I think other countries have been seeing what we've been doing in this town hall and trying to mirror this kind of approach to address healthcare challenges in their own context. So really thanks, Dr. Munoh, for your leadership, and thanks a lot for your insight. We recognize your burning passion for cancer and your zeal to see this end. So Dr. Munoh, over to you.
Okay. So Dr. Brian, thank you. Please, guys, my voice, I have a lot of cold, so I may have issues with my voice, so please just help tolerate that. This topic today, I am going to be very critical, more than I usually do, about how we approach healthcare in Cameroon. The reason is because we get to a point where we need to talk about relevant things and how to move forward. We cannot keep pretending that things are going to change on their own if healthcare workers are not able to advocate for what is right. I say this because every healthcare system is evaluated. I'm an oncologist, but that's why it's going to be a bit biased. But before, every healthcare system can be evaluated by the way it treats cancer. Cancer is one of those diseases that tells you how primitive a healthcare system is. If any healthcare system is not able to do an interdisciplinary approach in treating a disease and have specific screening, diagnosing, and prevention methods, and actually treatment methods in order to deal with cancers overall, then it's still a very primitive healthcare system. Even here in the US, I do still have primitive healthcare systems that are unable to tackle this problem. But the one in Cameroon, the problem is so difficult because it's multi-sectorial. And today, my presentation will be talking about how to improve things at different sectors. I'll give you an example. Today, I saw the release of specializations that came out in Cameroon. What struck me about it is that Cameroon is training more cardiologists than internists. It shows how naive those who are training, those who are actually in the process of coordinating care, think about care in Cameroon. No matter how much you want to improve healthcare, you cannot train 20 cardiologists and you train 10 internists. It's unacceptable. Actually, family care doctors and internists are supposed to be the guardians of the healthcare system. Our general practitioners, we need to start reorienting their teaching and thought process. How many GPs do think about screening of their patients other than infectious diseases? How many of them do know that there are guidelines by WHO, I'm not talking by specific countries, that require that certain diseases be screened ahead of time in a fragile health system like Cameroon, where we cannot treat cancer, but we can prevent it, as Dr. Dita said. Cancer care is expensive. Dr. Oko is going to tell you that I knew him. He's actually an Ivorian who is here. He's a professor at Emory. Cancer care is expensive. It's getting expensive every single year. You cannot train. I looked at the list. You cannot train 10 oncologists every year in Cameroon when you have a poor pathology department, where the pathology department is unable to even do its basic fish test on patients or to do immunostaining to identify patients who have ER, PR, and HER2 breast cancer. How are you treating breast cancer if you're unable to do that in the whole country? Or if only one lab in the country can do that, how do you treat breast cancer? How do you train oncologists if you're unable to do rudimentary things? It shows that those who take care of our health system are unable to understand the fundamentals of what goes into healthcare. So I would introduce myself a little bit. So I am Dr. Munoh Kenne Foma. You guys know me. I'm one of the founders and one of the moderators of the town hall. I trained in Cameroon. I worked in Cameroon, so I know Cameroon. If those who are doubting, I know Cameroon very well. I am an advocate in collaboration with Cameroon to improve it. But today I'm going to criticize certain things because they need to change. And I worked in Cameroon in the regional hospital in Bamenda, where they have been very kind to me. We do run tumor boards in Bamenda. And to me, that is the best tumor boards I have been to with bingo. I attend tumor boards at La Cantini, which is chaotic, one of the most chaotic things I've seen. And if that's how we're training our oncologists, then we are up to a very big challenge in Cameroon. I do also participate in multiple other tumor boards in Cameroon, which they have given me privilege to do so. I am a trained clinical pathologist in Cameroon. I have a master's in public health, more in preventive medicine. And so I may have the privilege to sit here, and I work as an oncologist. And just a disclaimer, I work with Presbyterian healthcare system. And this has nothing to do with Presbyterian. So I want to start with that disclaimer. I'm an oncologist, and I get to see more than 20 breast cancer patients every week. My focus is on lung cancer, but our practice is huge, so I tend to see about 20 breast cancers every week. So this is a disease I know about. So here is our little country, which is not so little, with more than 27 million people. And breast cancer is the #1 cancer. It has actually surpassed cervical cancer. And this shows that we are moving from viral infections, because cervical cancer is one cancer which is run totally by viral infection. And we are moving towards affluent kind of disease. Cancer is a disease of affluence, but it's a disease of age. Don't forget that. The biggest risk factor for all cancer is age. So when we talk about in oncology, there are more than 300 cancers, and that is why training is important. It's so important that we are able to have the guidance of the healthcare system. It should be the GPs who are also trained well, and their orientation needs to be taken away or shared between infectious disease and chronic disease as burden of disease is shifting. We need more internists in Cameroon to be able to make sure that they understand the holistic nature of healthcare. The way we do train our specialists is the way the healthcare system is fragmented. Now, there are two main types of malignancy, and today I'm going to concentrate on one. You do have lymphomas, leukemias, which are blood cancers, difficult to treat. Cameroon is doing a good job with pediatricians because there is a better pediatric-oriented care in Cameroon than what we have in internal medicine and the departments and the different departments. And we can talk about that later. Now, in solid cancers, breast cancer is the #1 in Cameroon, so we're going to talk about it. Burden of cancer worldwide, I just put this to show that this data is not accurate, as Dr. Ambefogu said, because we don't even have data. I'll tell you this, Cameroon does not have a national registry for cancer. Is so primitive. Just most of the data comes from Yaoundé, which is not, there is no integrated cancer center in all of government hospitals in Cameroon. None, zero. What you call an integrated cancer center. Baptist Mission is doing a great job to help us subsidize cancer care. And we have had multiple presenters who came in from the Baptist Mission to tell us what they do. But when it comes to the government itself, there is l'Hôpital Général Yaoundé. The MRI doesn't work. The cancer unit barely has nurses that are trained in oncology. They barely have irradiation. The radiation department has not been working for the past 15 years. It does not work. That of l'Hôpital Général Douala works. But you are unable to have integrated care in such a place where there is so much fragmentation and there is so much lack of interest. I know Cameroon has many public health problems, but you can see here that cancer is becoming a burden in Africa, which is underrepresented. In the world, breast cancer is actually #1 for women. And in Cameroon, it's #1 for all cancers. So it's a public health problem. This is the statistics in the US. I'm not going to talk about it. For those who are here who are in the US or Europe, you get to see breast cancer most common. The second most common cause of death is actually lung cancer, which in Cameroon, lung cancer is pretty down the list. Now, this is the statistics of what we have in Cameroon so far, from what I saw. But this statistic is based on case reports. Majority of patients who die of breast cancers are not reported anywhere. I will tell you this, the past, I'm very sorry, I just want to apologize. I know I get hundreds of mails. Oh, my brother was diagnosed with lymphoma. My brother was diagnosed with breast, but breast is the largest. I get in my inbox. And people want to get my opinion about it. At times I reply, at times I forget because there are just so many. And I think I was going to call you and I don't. And it's a problem. If it was not a problem, I know a lot of young girls who have been diagnosed with breast cancer who are close friends to me. I know a lot of family members. I know close friends who died of breast cancer. And the saddest story I always say is a young girl who had metastatic breast cancer. Why? Because she went to one of the big hospitals in Cameroon with breast mass, which if you just look at it, you understand it's more than a stage 3. Nobody did any imaging to figure out if she had metastatic disease. They did a mastectomy, which is useless. And I want surgeons, that's why I want all the surgeons to be here. Don't do useless things to patients. Which is useless. Everyone offers a mastectomy back home because they can do one. It's useless. This patient did not even have a CT chest abdomen pelvis. Got a mastectomy, and 2 weeks after, started coughing. They did a CT chest. They did a chest x-ray. There was mass everywhere, bone mets and everything. She had that mastectomy for no reason. The second part that summarizes the problem of cancer in Cameroon is that when her biopsy was done, nobody did any hormonal testing, and IHC was not done. Immunohistochemistry staining. It is so primitive that this is one of the things that have been going on for 50 years, and I don't understand why only Central Pasteur. Why big places with MRIs, if they can afford an MRI machine and put it in Bafoussam, then they can actually do an IHC. It shows that pathology is very rudimentary in Cameroon. A lot of people who pride themselves as professors, but they are priding themselves in the wrong thing. Why? If you cannot tell me the IHC of breast cancer, then you are not in the right position of treating breast cancer. I'll show you today. When she died, before they contacted me, I asked for the pathology to be sent to Central Pasteur and for us, and this is lack of education coming from everywhere, for us to do the IHC, the immunohistochemistry staining. She was 100% estrogen positive, 100% progesterone positive, but she died while taking chemotherapy. She never even had to take chemotherapy in the first place. This shows you how when you poorly train doctors, you poorly train people without the necessary need for pathology, availability of certain things, you get the results you get. This young girl had to be alive today. Those are patients I see every day. Someone who has a progesterone and estrogen positive breast cancer, I can give them more than 10 years just on hormonal treatment. And it's cheap. Tamoxifen is not expensive. She was young. So she died, but if you go back, the family was, oh, we did our best. Or we did breast surgery, but she advanced later. That's only the story that was told to the family. It's a sad story, but it's time for us to start reckoning what we do to patients. If you lack knowledge, seek for knowledge. It has nothing to do with intelligence. It just has to do with the way a healthcare system is controlled. So these are the different systems. And in Cameroon, these are the different integrated cancer centers that exist. There is Banso Baptist. You realize all of them are Baptist. Bingo Baptist, Baptist Hospital Mutengene, and Dopi Baptist. So these are, and then there is Chantabia Foundation for Children. They are doing an excellent job there. Why? Because in Cameroon, pediatricians are still trained to be general pediatricians before specializing. And this actually helps in care and how care is run. I will tell you that I can testify for you that the care given there is completely different when you go to malignancies. First of all, there's a fragmentation to know who a hematologist is. I trained as a clinical pathologist in Cameroon. You are not a hematologist, you're a clinical pathologist. They are two different things. I just want to crack that bubble. You are not trained to treat cancers. Neither are you trained to treat hematological cancers. You are what they call medecin biologist. That are two different things. And Cameroon is confusing a lot of those things, and it gets to a point where we get problems with how we treat cancers. I had another patient in CHU. I was called during the last minute. I looked up her blood work. The bingo actually diagnosed her and suspected that she had a CML, and that is what she had at the time, and sent her to Yaoundé, thinking they were doing a good job. This lady passed away in CHU with nobody finding out, up to the point where when we asked for a flow cytometry and a bone marrow biopsy, when the results came, she had already died. She had CML that transformed into AML. And it's sad to understand that you do have, there is a whole process in Cameroon where we need to start reshaping how we train young, intelligent physicians. They are smart, they are young, they are intelligent, but there is a lack of policy in order for us to really deal with cancers. So is there any screening method or any screening guidelines in Cameroon? No, there is none, officially none. There is no screening guideline officially in Cameroon for breast cancer or for any of the cancers. Zero screening. No screening guidelines in Cameroon for breast cancer. Now, do we screen? We do screen some people, those who are wealthy, those who work with MTN, those who work with Orange, those who work at the same pairs, maybe those who work in, but what population of Cameroon is less than 1%? Does the government have a policy to screen for the cancer that kills women the highest? No, we cannot treat cancer. We cannot treat breast cancer, and we need to accept that. And once we accept that we cannot treat it effectively for every woman who has breast cancer, then we need to learn how to screen. The goal of screening, as Dr. Dieter said, is for us, it's one of those cancers we have had evidence for many years. It's for us to identify these women young, early. We are able to do interventions that we can actually help cure them, get them into the healthcare system where they can be surveyed over time, and then we are able to actually save lives, appropriately save lives. Now, how do we screen for breast cancer? There are certain things which this is a controversial discussion I would have. The American Oncology Association does not advocate for self-breast exams because everyone has access to a mammogram in the US. Clinical breast exams, we do not advocate for that because everyone has access to a mammogram. We do advocate for what we call breast self-awareness. Just know your breast. But in Africa right now, and in Cameroon in particular, with lack of access to mammograms, lack of knowledge, I would advocate for self-breast exams still. Examine your breast, know your breast, get used to your breast, get your husband to understand and know your breast. And if there is any change, which we are going to talk about, please seek help. Seek help from a professional. Get a mammogram. But my advocacy will be more for the government, for everyone to be able to adopt a mammogram screening and preventive health. If you are not training enough internists and enough family doctors and training the general practitioners appropriately, you will not have guardians of healthcare who will be able to screen patients not only for lung cancer, breast cancer, colon cancer is even worse than all of what I'm talking about breast. So there is a major problem. Now we get to do mammograms, ultrasounds, and MRIs. In Cameroon, so far, by the government, there are 4 functional MRIs. In Yaoundé, the military hospital. In Douala, I think l'Hôpital General has one. I don't know if it's still functional. I don't think it is. There is Bafoussam, the new intermediate hospitals has one in Bafoussam and in Gaoundéré. That is all. For a whole country where we train doctors, not even in those hospitals, in different hospitals, and those hospitals do not even have access to advanced technology. Now, there is always this question of what causes breast cancer. This can be a whole long discussion, but I want all the ladies in here to know that despite everything we talk about breast cancer, the risk of you getting breast cancer is because you are a woman. It's 500 times more common in women than in men. So just being a woman is the #1 risk factor for breast cancer. Let's take that debate out. So being a woman, so the fact that you're a woman without any risk factors, I'm gonna screen you. Age. Now for women, in order for us to have a significant impact in public health screening, as you age, also the risk of breast cancer increases. And that is why we start screening women depending on what guideline you're using in what country. I would advocate for WHO in Cameroon just because we are not able to afford to screen patients from the age of 40 and yearly, the way we do in the US. You can screen patients from 50 and biannually, or from 40 and do it biannually. That is still very efficacious. And a lot of European countries do that. This just shows you the trend between breast cancer and colon cancer and how age affects them. Age is the biggest risk factor. Now there are other risk factors. Others would ask me, oh, Dr. Kenne, you're talking about Munoh. You're talking about breast cancer. We've been hearing over the news. There are all these other things you didn't talk about. Yes, BRCA gene is one of those risk factors, BRCA1 and BRCA2. One of those risk factors that increases your risk for breast cancer relatively by almost 10-fold. But BRCA cancer is responsible only for 5% of all breast cancer or less. So we need to know this and not feel that each time someone has breast cancer, they do have BRCA, but BRCA gene 1 and 2 is responsible for that percentage. Now, there are other genetic predisposition, genetic related diseases like Li-Fraumeni. For those who know it, I know a Cameroonian who had Li-Fraumeni disease here in the US, and it's common in Africa, just that we're not testing it and we're not inquiring. Cowden syndrome, there is Busch-Jaeger syndrome, there is CDH1, there is PAB and all of that. Those are all things we test for. But in Cameroon, it's going to be difficult to test for it. One of the ways is to do a family tree to patients who come and see you and understand if they have cancer in every generation. It should be a call for concern, meaning cancers don't skip generations. Early menarche. Our young girls are having their menses earlier, so they are more exposed to estrogen and progesterone earlier because of development and advancement and food alteration and many things. There is what in gynecology they call the rainbow syndrome, where you have an early menses and a late menopause. It increases your exposure and it increases your risk for breast cancer. Late age of birth of your first child. That is, we're having our mothers are becoming working mothers and they are giving birth very late. And this is also a risk for breast cancer. There are other benign lesions that we'll look at. Hormonal replacement therapy does increase, but not hugely. Alcohol consumption, which is a big thing in Cameroon, men and women drink alike. Family history and other cancers. So there are some things that do reduce cancer risk, which when we're talking about cancer in Cameroon, I think we should lay emphasis on them. Make sure more than the other 20 or more breastfeeding, importance of breast milk and breastfeeding in children, it helps reduces breast cancer. Having pregnancy at age less than 20, I'm not saying we get teenagers to be pregnant. And ovarectomy and exercise, because obesity also increases breast cancer because fats store estrogen and you can convert them. So this is a nice prevention risk model that I usually use in order to explain to my patients the things that cause breast cancer and the things that we can do. There are modifiable risk factors and non-modifiable risk factors. You cannot change your gender. You cannot change your age. You cannot change your genetics. You cannot change when you start menstruating. You cannot change your family history. You cannot change your menopause. You cannot change exposure to radiation if you had Hodgkin's lymphoma or any kind of malignancy that had to be treated. So the top ones are things that we cannot change. The bottom ones are things we can change. We can start encouraging women to plan their lives, have children early. We can also help women not to give birth late. We can tell them to breastfeed babies. We can use other modes of contraceptions if they are available. We can tell people to eat healthy. We can ask people to exercise and also reduce obesity, which is one of those things that leads to breast cancer. Here are the genetic predisposing factors that I said, and these are some of those things that you can see in a family. Now, there are other benign lesions that can increase your risk for breast cancer, which like lobular carcinoma in situ and ductal carcinoma in situ. These are several other things. They are very medical. We can talk about it if people are interested. And to me, once you have this, if you train good internists, you will realize that women will be stratified and some of them will be placed on preventive measures. We have tools that exist already. We have the Gale scale, we have the Triers circuit skills that help us to classify women who do not yet have breast cancer, but who have high risk to develop breast cancer and place them on preventive medicine. And this reduces breast cancer reoccurrence or breast cancer occurrence. And this is something that is available. And this is something that your guideline directed therapy needs to be used, and you need guidance of the healthcare system to help you with this. For those who are interested, here are some of the clinical trials. I will not go into the details, but you can use tamoxifen, roloxifene, exemestane, and anastrozole. I found out all these medications are available in Cameroon, and some of them are very affordable. But I could not understand why metastatic breast cancer patients kept getting chemotherapy when they are not having a visceral crisis. And when no one has done an estrogen and progesterone level. And most of them die in this chemotherapy because we don't even know how to give it. We don't have nurses that are trained. There's one thing in Cameroon that we do a lot. We decide healthcare has a problem, or let's create 100 medical schools. But nobody creates a nursing school. Nobody creates a school for radiation technologists. Nobody creates a school for physicists. Nobody creates a school for those who would help these specialists work. And your outcome becomes zero because you're doing the wrong thing. You can't create 100 medical schools when you are not even able to create one subspecialty nurse. These are the people who give these drugs, and that is why most of our cancer patients die. I had my aunt, before she died, when I went to Yaoundé, I was talking to the kids. I heard she was just diagnosed of colon cancer, incidentally. And I asked her, why don't you go to l'Hôpital Général? Very well-educated woman. She's like, everybody who goes there dies. They die the next day or 2 days because what happens? We give them neutropenic fever. We don't have any control over it. And patients do die of sepsis. So these are some of the strategies that we need to be able to do. And if we think that healthcare is all about physicians, we're making a big mistake. Physicians play a very little part of healthcare. And if we want to improve in Cameroon, we need to train everyone. So here is just preventive methods that are evidence-based medicine. This is for those who are in the US and those who are also in Europe. This is evidence-based medicine. Those who classify to be high risk, you can actually place them on preventive treatment, which is going to reduce the chances of them getting breast cancer in the future. And these are things I would love us to teach our general practitioners, that these things exist. The past 5 years, I've been doing a lot of research in Cameroon because people contact me. And I found out that we have tamoxifen, we have exemestane, we have anastrozole. The prices were astronomically low. I have some few, like Bamenda is doing a wonderful job. The gynecologists there, they are doing an excellent job. I think they need to be a center of reference. Why? Not because they just do the right thing. Every patient there is getting an ISC. Every patient there, I had a 90-year-old that was presented to me. I don't want to reveal the patient, by one of the oncologists, estrogen and progesterone 100%. We started the patient on anastrozole. That was it. Normally, people are going to, what I realize is nobody does this. They will tell you, they'll give you excuses, which I got from La Cantini. Oh, doctor, c'est parce que c'est très cher. Who said examen? You are going to give chemotherapy that each session is $1 million. And you cannot do an ISC in Central Pasteur. I asked them, why can't you even do it in La Cantini? How on earth do you guys make that amount of money and you cannot invest it in pathology? So to me, one of the biggest problems of cancer care in Cameroon is that we have a very weak pathology department, extremely weak. We have physicians who do surgeries and nobody sends those specimens for pathology. Nobody sends specimens for pathology, rarely. There are many patients who come in with perforated abdomens, with colon cancer in it that nobody actually did send for pathology. Appendiceal cancers, many things like that happen. We do resect nodules in the breast, we just allow them. Nobody sends for pathological analysis. Even when you send to pathology, you don't have the appropriate things that you need in order for you to help treat this patient. So in terms of prevention, which is where I'm going to lay a lot of emphasis, we can do prevention by giving medications to high-risk women. We can ask people to exercise. We can ask them to limit alcohol, especially in Cameroon. Now, the most important part of my talk. I think if the talk goes on, I will be able to stop halfway just because I want to lay emphasis on this part, screening. What is the problem with screening in Cameroon? Is that it's not even a strategy. It's not a healthcare policy. It's not a policy in most countries, and it's not a policy in Cameroon. Most mammograms are owned by private individuals. Most regional hospitals do not have their own mammogram. It shows you that the government doesn't think about it. I think the regional hospital in Bamenda about 2 months ago got a mammogram. Good thing. Advertise it, tell the public to come screen. Tell them, make it affordable to all women who can have access to it. Educate the gatekeepers who are the general practitioners that every woman above the age of 50 needs a screening mammogram every 2 years if they can afford it. And let it become standard of care in Cameroon. These are not rocket science policies. I'm not even telling you what we do here. I don't want you to start doing next generation sequencing on things like that. No, no, no. Let's do rudimentary things that we have done. They have been done in Europe and in America since the 1950s, and we know they work. So we are still so backward in the way we think about healthcare that each of us think a lot about ourselves. Here are the different strategies. Our primary doctors need to evaluate women at the age of 30 just to get their family history. If they have history where there is no skipping of generations, then you start thinking on getting them screened at the age of 30. If they have had a family member who had cancer at age less than 30, you have to think about screening for these women. And how do you screen for those who are less than 40? You do an ultrasound of the breast, then you can do a mammogram. Now in the US, we do screen everyone above the age of 40 goes for a mammogram annually. We can afford that, but WHO says 50 years biannually. If Cameroon can adopt that, that would be nice. If we cannot adopt that, each individual should take it as applied in order to make sure that this is done. I'm planning to give a series of 3 lectures or 4 to physicians in Cameroon on how to manage breast cancer, because that is going to be more detailed. This shows you different countries and different guidelines. I'm not going to lay emphasis on them. Those who want to have my slides, you can have it. And you would see here that the guideline changes from country to country, but there's one pertinent thing. Everyone agrees that women from 50 to 75 should be screened biannually. Everyone agrees that. Now, what about access to mammograms? It's deplorable. Even when you want to do one, having access to it, access may not only mean it's available, but how affordable it is. Is it a diagnosis of prestige meant for only those who work at MTN, Orange, maybe and those who work in all the big banks in Cameroon who have insurance? That is less than 1% of our population. And that is why we get to diagnose all breast cancers late. By the time you're palpating a mass, I've told those doctors in Cameroon all the time, they are my colleagues, they are smart, extremely smart, but they just need orientation. By the time you're palpating a mass, most of the time it's metastatic disease. Don't treat it locally without doing a CT of the chest, abdomen, and pelvis. You'll be very surprised. I had a case recently, and I had to fight with the physicians, like practically fight with this physician in Douala. A woman comes in with breast cancer, diagnosed 2 years ago, a lump, comes back with the lump, and goes sees a gynecologist. They want to do mastectomy. And I tell them, why are you doing mastectomy when you have not even done a CT of the chest? Because this woman has had this for a long time. The mass looks large. It looks to me like a stage 3. And it was a whole fight over the phone for no good reason, because everyone wants to be protected. The goal behind, when we did a CT finally, without him even knowing, there were meds everywhere. There were meds everywhere. And we have a problem even with interventional radiology in Cameroon to be able to get samples. Even getting the sample from the breast was biopsy, but Central Pasteur said there was no cancer in the breast biopsy. So that became questionable to me, what was biopsy? And it becomes, and even there, nobody asks for an ER-PR state. So it's sad. It was a lot of hurdle for me to try to help, but I found out the system in place, everyone wants to be protective. This is breast ultrasound. This is breast MRI. I'm not going to talk about it because we don't even have MRI machines available everywhere. And these are just the advantages of doing an MRI and a breast ultrasound. This is an algorithm we use in order how we do screening. This is mostly for breast surgeons. And one of the problems in Cameroon is that gynecologists are feeding in for breast surgeons, which breast surgery is a subspecialty on its own and has so many malignancies that they need to take care of. And I think we need to start thinking about subspecializations in surgery and understand that the breast may annoy gynecologists, belongs to the surgeon, not the gynecologist. Better. So these are just things I've discussed already, what we do. Now, in terms of staging, this is a purely public health lecture. What I would say here is this chart. I call it, this is meant for us to use for training. And I would want everyone take a picture. You can always go to the Lemon Knowledge app where you can download it for free. It helps you, and Orange helps you understand the different things that women need to look for in their breast. If a woman realizes that she has hard area in the breast, you see the lemon there, you can easily see a dimple, a nipple that has crest around it. You have redness in the breast. A lot of people think redness in the breast can be abscess, but if it stays for more than a week or 2 without getting better, it is most likely cancer. Discharge coming out from the breast. You do have patients who have bumps in the breast, veins that were not there, sunken nipples, peau d'orange, that your body that looks like orange peelings, heart lump. Those are all things that we should take note of. And this also, I usually love this because it helps you just see exactly what the different structures are. You tell women about lymph nodes, they don't know how it looks. Just think about a bean plant, and if you palpate anything in your armpit or the axillary that looks like a bean plant, then you think that's actually lymph nodes. So here are actually some of those symptoms. I've spoken about this for the sake of time. And what we should do, which there is another problem I want to raise in Cameroon, biopsies. The act of doing the right biopsy is a big problem. We need training. There are a lot of people who are well trained in Cameroon to do this, but a core biopsy is better than a fine needle aspiration. We can also do excisional biopsies, but the problem with excisional biopsy is that most of the time we'll have to come back. If we have a good pathology department, in order for us to actually do excision of the cancer, if we do have cancer, and do proper lumpectomy. This is where my biggest beef has been with Cameroon in the last few years. I have examined more than 30 pathology reports in Cameroon. They do not meet the standard of accurate pathology reporting. So it means we have a problem in pathology. I was a trained clinical pathologist in Cameroon, but anatomal pathology reports, no matter how those professors grade themselves, they are doing a bad job in training and training of their young ones. The histology subtype is usually there. Grade is usually there. Nobody reports the estrogen receptor levels. Why? Maybe because it's done only in Central Pasteur, but I don't know why they cannot advocate to be able to do this. This is rudimentary technology that has existed for more than 50 years. Nobody reports the progesterone levels. Nobody reports the HER2. What is sad about breast cancer is that's why I don't even want to go about treating. You cannot treat the list of breast cancer without knowing these markers. It is completely medically illegal to do that. Completely medically illegal and criminal. If you've been doing that, it's criminal to do that. You could go ahead and start treatment and try to get this. And the complaints I've had from La Cantine, I participated in their tumor board, was that it's too expensive. How can a test, which is worth 100,000, be too expensive than giving a patient chemotherapy worth millions? Where if you did this test, the patient may never be on chemotherapy and end up taking a medication less than 10,000 every month. How do you advocate and accept this kind of practice in Cameroon? I told you today is going to be very harsh because I think we need to talk about this. I'm not going to talk about MRIs here. Staging is something which is purely very medical. And what you need to know is that anytime you suspect a woman has greater than stage 2 breast cancer, please do additional testing. This is for all the physicians. Do a CT chest, abdomen, and pelvis. It's 50,000 in the Northwest. Do one. If you have a woman with an alkaline phosphatase that is high, most likely there is metastasis to the bones. If you have them coughing or having other symptoms, try to rule out. If the axillary lymph nodes are positive, do staging workup. For treatment, I have additional 4 minutes. Treatment is very complex. In the past 20 years, we have had more targetable treatments in oncology than anything else. Chemotherapy has stayed constant, but in Cameroon, we cannot even afford to have access to chemotherapy. We don't have access to people who are trained to give chemotherapy, which is a big problem. Because there is no access to people who are trained to give chemotherapy, it becomes very difficult for us to appropriately give the chemotherapy. And this is because there's been lack of training for nurses, not for the physicians. If you don't train the appropriate subspecialty nurses and you keep proliferating medical schools, you are doing the wrong healthcare system in Cameroon. Cameroon is actually very bad at health policies and making decisions. So today, I will not go into the details of treatment. All what we need to know is that in breast cancer, we do give neoadjuvant treatments. Let me go over to, there are several types of things we can do: surgery, radiation, chemotherapy. But what I want to talk about more is this aspect of, there are things that I talk about which are very, should women in Cameroon get breast conservative surgery or should they get a mastectomy? You may find me being very harsh. The women may say I'm very harsh on this. I think the oncologist in Bingo said this to me. Mastectomy is equal to breast conservative surgery plus radiation. If you don't have access to radiation, then you cannot be doing breast conservative surgeries. Most pathologists have not even been able, I've looked at all the pathology reports, tell me if the margins are negative, how many centimeters of the margins are negative, they don't even report it. And these women have only one radiation center working in Cameroon, or two, one in Douala, private. He had to be here with us today and had a different commitment. That's how I ended up presenting today. So it is very important that we understand that we may want to preserve their breast, but we may be unable to do it because we don't have access to radiation therapy. So mastectomy is only equal to breast conservating surgery, that's lumpectomy plus radiation. Axillary lymph node dissection is a whole thing. I will not talk about it here, but if there are questions, we can chat about them. And no surgeon, I keep hearing this over and over, please don't be confused. There is no need for us to be doing radical mastectomies anymore. If your professors were trained in the 60s with the Trustadian philosophy, it is out of place. No removal of the pectoralis major and the pectoralis minor, you don't do that to women. There is no improvement in survival. Every woman needs a simple or a radical modified mastectomy. Nothing like what you find in this other picture. Don't do that. To any woman, don't do it. And that is why it's important that I spend time talking about this. Now, this is a very important slide for me because it helps you tell you the percentage of breast cancer and the different subtypes. The reason why my goal in Cameroon in treatment has always been to educate people about this is because 80% of all breast cancer is estrogen and progesterone positive. What does this imply? It implies that most of them do not need chemotherapy. That's the implication. And that is why you need to do it. In the neoadjuvant, adjuvant setting, and metastatic setting, you need to do it. ISC, if there is one message in treatment, is that ISC is the most important thing in breast cancer. HER2 is responsible for 20%. This becomes complex in Cameroon. The other day, I tried to give someone Herceptin in Cameroon. I think it cost almost $1 million to do that, which is a drug we have had for long. Why can Cameroon not get a subsidized form of it, the government itself? Triple negative becomes complex because everyone needs chemotherapy. But this diagram tells you that 80% of those who are diagnosed with breast cancer do not need chemotherapy or may not need it. Because in Cameroon, we are unable to even do the Oncotype DX to figure out, but women don't benefit much from chemotherapy. This is the second most important in summarizing treatment. Anyone who has an estrogen positive breast cancer, which is HER2 negative, the main treatment is endocrine therapy. This is for the doctors in the house, even the oncologist. I see them keep giving chemotherapy because they don't do these levels. Studies in Nigeria, in Ghana, in Ivory Coast have shown that the hormonal levels are the same like what we find here. I had some other people try to look for studies in Cameroon. We don't even have hormonal levels because nobody tests them. In Cameroon, it's scandalous to even tell people that nobody tests for this. If someone has triple negative breast cancer, it's chemotherapy and hormone and immunotherapy. Immunotherapy is not available in Cameroon. If you do have HER2 positive breast cancer, then HER2 directed therapy is the gold standard. So I'm coming to the end of my lecture today. There is just so much I wanted to talk about. Third, I want to give time for us to reflect about what is important. What I can tell you today is that after the time I have taken in order to look at breast cancer in Cameroon, understand what is going on, I got to realize that the problem is a systemic problem. The first problem is a public health problem, where we need to advocate to the Ministry of Public Health to prioritize breast cancer. If not, we are not going to be able to screen women effectively. We cannot be putting MRI machines in every place where we can take them and buy hundreds of mammograms and make them available. It's just a little bit of health economics and prevent us from even treating the cancer in the first place when we don't even know how to treat it. Prevention is better than cure. It has never been evident. Second, we need to educate and train our general practitioners. Why? Because if they are not trained on preventive medicine, not infectious preventive medicine, but general preventive medicine, which we are having an epidemiological transition right now. Most of them sit in the hospital waiting for patients to come when they are sick. While we could also use the opportunity to ask those women, I practiced in Cameroon, I was a general practitioner in Cameroon, and ask those women to get mammograms and ask those women to get pap smears, and ask gynecologists are good at that. And ask those women to also get colonoscopies and men to get colonoscopies. We can prevent a lot of this. The next thing I want to talk about is training of our specialists. If we are not able to hold the pathology department accountable in Cameroon, you can never develop a good oncological program without a good pathology department. Garbage in, garbage out. No matter how intelligent the people are, we have very smart doctors. I train with a lot of them in Cameroon. If you are unable, even the other day, one of my colleagues sent me a pathology that was sent after the patient had a uterine hysterectomy with uterine cancer. The pathologist actually said nothing in that thing to help this guy to see if it was staged. Does this patient need further chemotherapy? What stage is it? What FIGO stage? Nothing was reported there that was helpful. It was just that the patient had uterine cancer. Unacceptable for us to be accepting things like that in Cameroon. We need investment. Every regional hospital needs a pathology department that can be able to do immunohistochemistry. The next thing is for the oncologists that are being trained in Cameroon. We need to be able to, if we don't have interdisciplinary teams, we cannot work as teams because oncology treatment relies on how good the surgical department is, the different surgeons, the different pathologists, the different radiation oncology department. We have the worst rudimentary radiation oncology department back home. Most of the machines are not working. Those who are even trained cannot work. They are not trained auxiliary staff, which I'm coming to. You cannot give chemotherapy when your nurses are not trained in the side effects of chemotherapy. When you don't have schools to train nurse practitioners who are able to help you out. You don't think you are a Superman to train 100 million doctors and think your healthcare system is going to get better. It will not. It goes for other specialists. That is why most patients actually tell you that once they are diagnosed with cancer and they get chemotherapy, it's a death sentence, because it's true. Most of them die of neutropenic fever. The oncologist killed them. The last part about it that I want to advocate for, just going back to the next part, there's no school to train physicists, real physicists who are going to work with radiation oncologists. And it saddens me. The last part about this is health education to the public. Breast cancer is a health emergency. We need our mothers and our sisters alive. We need to prevent them from getting the disease, diagnose them early and treat them, and provide adequate treatment to them. We can talk about treatment. I treat breast cancer every day. We treat it. It's getting more complex in treatment. It's getting more expensive. Healthcare systems that are fragile cannot sustain it. So that is not where I think we should put our emphasis on. Fragile health systems cannot treat cancer. That's very clear. They would crumble. Like dust, they will crumble. It's super expensive. So way forward is that we should strengthen the whole healthcare system. Cancer is a marker of poor healthcare system. If a healthcare system cannot afford to screen and help people from getting sick, then it's just what less for us to talk about how we take care of those patients. So I'm very, very sorry today that I may have been very harsh to a lot of those who are back home, and they may feel that this has been a big criticism, but it's worth it. It's worth talking about it because we need change. So over to you, the moderators, for us to have a good question and answer session.
Welcome, Elvis.
Thank you, Brian. It's a pleasure, and it's been a very electrifying presentation. You know, when someone is so passionate about something, he can't keep the emotion aside, right? That's why you can see how emotional Munoh has done this presentation, because it's something he cares so much about. It's something he deals with every day. And that's why he's passionate about, and he wants to say it in a way that will really touch our marrow for us to see the importance of this problem in our society. Thank you very much, Munoh, for this excellent electrifying presentation. I've been listening without, blinking from the start of the presentation till the end. And I'm sure, Brian, you have done the same as well.
It's electrifying. I think when you listen to Munoh, you can sense, you can smell the passion, the zeal, the energy, the enthusiasm to see this problem really being addressed. I think he's highlighted some of the key challenges around this topic. It's just electrifying listening to Dr. Munoh. He has tremendous passion for the topic, and I'm also looking forward to the Q&A with the rest of the audience. So
absolutely. And Kate, surely.
What more can I say, actually? I think this is the first time that Munoh has really been critical on the Cameroon Town Hall. I think we need to come back to our senses, and even as some people are putting in the chat, we all know cancer care is quite expensive. But we know we need to set our priorities right. I think that's what Munoh was just trying to hammer. And if we do so, we should be able to at least catch a good number of people who are dying unnecessarily because of breast cancer. So I lost someone in the family just 2 months ago to breast cancer as well. So this is a topic which it's real, actually. And she actually had bilateral radical mastectomy without even telling me. Like, I was in Cameroon, I found out later. And so, it's complicated, and hopefully, well, keeping the sad story away, I think let's go on to the Q&A and see what we can put forward as some form of a recommendation at the end of this particular session.
Yeah. I agree with you, and as well, I lost someone, of course, recently to breast cancer. So I think most people in the town hall should have this kind of experience or testimony as well, and what happened to their patient. And one thing I like about Munoh is that sometimes he touches some of those very basic things that might seem so basic but very important in the in the entire journey as far as care is concerned. Just highlighting the importance of training oncology nurses. You see, it sounds so little, but so important when it comes to treating cancer patients. You can treat patients and manage them adequately if you can understand the side effects of the medication and trained to manage the side effects. So just training oncology nurses is an important thing. So it doesn't suffice to open 10 medical schools and try to meet up with training so many doctors, while some other key specialties, basic specialties, are lacking behind. So I hear you, Munoh, when you point on some of those really basic things. So time for Q&A. Take it over, Kathy.
All right, I think we already have some reactions, and I think that there are a couple of hands that are up, and we also have the chat of the Zoom buzzing. So, but I'm going to start with Mayanwi, Didian, so you can go on. Please let us try to be brief with our questions as well. And I know the chair is going to give some brief and direct answers so that many more people can participate.
Thank you so much. Thank you, Dr. Munoh. That was really electrifying. It was quite insightful. I have two questions I want to get your insights on. First things first, about the screening. In the US, as we know, the American Cancer Society recommends against self-breast exam because no studies have proven any mortality benefit. I went to med school, the faculty in Yaoundé in 2011, left in 2018, and we were taught about self-breast exam and it being something very pivotal. I haven't looked at the research critically to know if the recommendations are based off research in resource-full settings or resource-limited settings. So I wish to get your thoughts on that in resource-limited settings like ours back home. And the second point I just want to get is, you highlighted something like the quality of care we give to people who are cancer tells us about how advanced the healthcare system is. But I also believe that we are suffering a lot from basic aspects like access to healthcare. And one of such metrics are things like maternal mortality rate or mortality of infants under 5, which in Cameroon, I believe there's a political will because that number has been trending downwards. When I joined med school, I knew that number off the top of my head. It was 651, but I just checked during this presentation and it was like 458. So there's a political will for that. And it's even better than those of other countries, like Nigeria is in the thousands. Chad is more than 1,000 maternal deaths per 100,000 population. So I just wish to find out what you think can change, or your thoughts about the political landscape, because if there's no political will, I think we'll keep buying MRIs rather than mammograms. So I just want to get your thoughts on that and what you think we can do.
Good. Excellent questions. I'll be very brief. Question number 1, concerning self-breast exam, there is no evidence. We're practicing evidence-based medicine. There is no evidence that doing a self-breast exam reduces mortality from cancer, breast cancer, none. But in resource-poor countries, most women who have been diagnosed with breast cancer is because they examined their breast. That's evidence also. There is a difference between practicing medicine in the US and practicing medicine in Cameroon. Why is there no evidence? Because we do mammograms yearly. So the effect of self-breast exams, or doctors, even doctors examining women's breasts in the office, I don't do that. I examine, a woman comes to me, she had a mammogram 2 weeks ago. This is disclaimer. I do not examine her breast. Why should I tell her to naked herself? Let me examine her breast. It's a useless practice. I could examine it for other reasons if she had surgery and other things. If she has not, if she's having biannually, that is different. If she's having it every 2 years, because some women opt for 2 years, it's a painful exam. Then you can do a breast exam in the next year. if a woman has a mammogram, you are never going to be as efficient as a mammogram in picking up lumps. There is what we call in the US breast awareness. It's like know your breast. We don't say go examine, know your breast. So when you see any kind of change, it must not be a lump, then you understand that you have to see a doctor and get a mammogram. Different from Cameroon. Most of the time in Cameroon and Africa, access to mammograms is basically zero. Less than 1% of women have access to mammograms. I'll tell you the truth. It's mostly those who work with international organizations where they use guidelines from their countries to treat their workers. And they get mammograms every 2 years. The rest, what makes another woman to go to the doctor and talk about breast? It's just because she saw a lump, she saw something change, she saw a nipple invasion. That is why she went in the first place. So back home in Africa, if you do the research, it's going to make a difference. We don't do research. It's going to make a difference because you don't have the mammogram, which is actually one of those factors that is confounding it. Here in Cameroon, it will make a difference because 90% of all breast cancer is because someone saw a lump or noticed a difference. Is that okay? That is, and you should be able to differentiate. It's sad, but in Cameroon, we have professors who think that evidence-based medicine prioritizes expert opinion. Expert opinion is stage 5 of evidence. It's nothing. Those who think that they were got in medicine, they are not. Okay? They are not, and they need to learn to understand that they are junior, the students they teach can acquire knowledge, and knowledge is accessible and available. The second question concerning, that's why in public health, I am a public health physician also, and I'll tell you prioritization is very complex to the government. You need to put your money where you would have impact. In maternal mortality, Cameroon has made great strides. We have improved, that is good, because we put our money where our mouth was. I can recall talking to Professor Mbo back in the days. Dr. Ombako is going to know this. We're one of the first that were trained in order to do maternal health care in Cameroon back in 2008, 2009. Ombako did a whole project, multiple projects, which they adopted later on. And it's been a good thing. But our mortality, we should not pride ourselves comparing ourselves with Chad. Okay? We should not pride ourselves comparing with Chad. We have still not reached the level we were in 1980. We're still worse than what we were in 1980. So, and you know what happened in Cameroon? They stopped training midwives. Cameroon's problem is always in nursing. My mother was a midwife trained in 1979 and a registered nurse. Cameroon stopped training midwives in 1988, right? Up to 2000 and something. I don't know if Elvis will remember the date. Stop completely. When you stop training midwives, what happens to mother and child health? It crumbles. In the US, there have been data that has shown that midwife delivery compared to gynecology delivery has the same outcome. You'll be very surprised about this, but it's true. Midwives have their place, and Cameroon had to go back and train midwives. The reason I'm saying all of this is because let's go back. We understand healthcare is complex. They have multiple problems going on, infectious disease, HIV, TB, and we need to prioritize. But should Cameroon prioritize in providing care for cancer patients, or should they prioritize in training people to screen early and prevent cancer? Which were you going to do? You would do prioritization to prevent, screen. It's going to have better outcome. It's going to be a cost-effective method. That's all I can tell you. We are not even approached the level where we can treat cancers adequately, trust me. We have not. We don't have the tools. We may think we don't have the tools to handle metastatic disease. We do not. We're so primitive, we don't have it. That's just the truth about it.
Yeah. So I think, yeah, thank you so much for that response. I'll, of course, Dr. Mutaze.
Yeah, thank you so much, Munoh, for that passionate presentation. I mean, many of us in this forum worked in Cameroon before leaving Cameroon, so we travel to Cameroon regularly, so we know the setting. It's not like people are talking as if they don't understand the realities of what is happening in Cameroon. One thing I would just like to say is that, just like Munoh said, care for cancer is a reflection of the health system, and we know that given the economic situation in Cameroon, we have a weak health system. There's no refusing that. There's no denying that. In Cameroon, we have a weak health system. But the issue now is that with the weak health system we have, we can do better. We definitely can do better if we are structured and organized in the way we do things. So one thing, I always ask this question, right? Cameroon produces lots of specialists, and then we have a lot of professors. However, people are becoming professors based on dozens and dozens of publications of case reports and case series. And I keep on telling some of my friends and colleagues that this is not going to lead us anywhere. All these case reports and case series are going to lead us nowhere. We have a chance here, for example, taking the example that Munoh presented. If we go to the different hospitals, Hôpital Général, La Cantine, all those hospitals, and we say, let us evaluate what is the standard of care, in each of these hospitals, then we can provide solutions to improve. Some of these doctors are actually doing the best according to the best of their knowledge, so they don't know better. But as training goes in Cameroon, people are taught that when you graduate from medical school, you graduate as a specialist, generally means you know it all. And that's the first thing that we need to change in the mentality. And we as people in this forum, I think the discussions that need to happen is that those who are in charge of cancer care, those who are gynecologists on this forum, surgeons who do mastectomies, let us try to come together with people who have skills in research design, like myself and other people here. Let us come together and say, okay, let us generate a couple of cohorts of patients who have been treated and see what their treatments are and see their mortality, 5-year mortality, 10-year mortality. Those are simple things we can do. It's very cheap. We don't need a clinical trial for that. Then we can start looking at ways to improve care. Cameroon, like many other countries, has problems. We're having cholera outbreaks, which means we cannot even give our people clean water, which means that we have a lot of other problems. But in terms of preventable morbidity and mortality, one way I would suggest that we do going forward is that people in this forum who are treating patients, the gynecologists, surgeons, oncologists, let us get together and start something. Let us look at each institution, each facility. Let's first describe what the standard of care is, and then let's start picking out the things like what is the cost of treatment? How are these medicines being procured? How are these patients being followed up? Then we can now try to make some of these changes and show with evidence that if you improve this or you improve this, then you're going to make a change. I think that is, I'll leave it at that because there's a lot more to say, but I will leave it at that. Thank you.
Wow, thank you. Thank you. So Dr. Motaze, as I call him, he taught me a lot of the little surgery that I knew. We used to do a lot of surgery in PMI. So we worked together in Bamenda. He was my senior in school, and we did a lot together, a lot. So most of it was reactions, which I agree totally. Dr. Motazer is a professor in clinical research. And I think there is no better way of influencing healthcare than having data. Anyone here who has worked in healthcare, who does healthcare, clinical healthcare, and has a background in research is going to tell you there is no better way. So I totally agree that knowledge is power. Research actually is the best way of influencing healthcare and getting data. So I agree with everything Dr. Motaze said. And one other thing is recycling our knowledge. So the sad part about, there are many specialties in medicine. But if I tell you, if I stop practicing oncology today and I come back in 2 years, I will not be able to treat 90% of the cancers. Some may laugh at this, but it's true because cancer care changes like nothing else on earth. Among all the research going on in the NIH, which are registered clinical trial, 90% of them are in oncology. The rest 10% are in all the rest other fields in medicine. So there is no better way than telling you how much research is important. In oncology, research is super important. So over to you, moderator. I see many hands are up. So
yeah, many hands are up. It's getting interesting. I don't know if I should come to you, Brian, before, but I don't know if Dr. Eko, because he's been in the chat as well, the regional delegate for the Southwest region, if you would want to come off mute and make maybe a question or some comments that you've been putting in the chat. I don't know if you're able to do that at this point. If not, I'll go to you, Brian, before I go to Dr. Dita.
No, thanks a lot, Kate. I think, and I would love to hear Dr. Eko's views as well. He's highlighted some really critical points that I would love to hear Dr. Munoh's in the chat, which I would love to hear Dr. Munoh's address as well. But Dr. Munoh, my key question to you really, I'm really curious if in your experience and really looking at how other countries with low resources like Cameroon have you seen any successful patterns in terms of the implementation of really evidence-based strategies in the management of cancer? Have you seen any countries with similarly low resources? And what are some of those lessons that we can learn from those countries in the context of Cameroon?
Yes, excellent question. Rwanda, Kenya, a lot of East African countries. What have they done? They have laid emphasis on prevention. Meaning what? They have made sure that doctors are trained to be the gateway. Family doctors are trained to be gateways of the healthcare system with nurse practitioner or advanced nurse practitioners, where patients are strictly followed on all cancer screening guidelines as per WHO recommendation. So when they start, what do? They realize where their weaknesses are. Let's make mammogram available in every region as we have x-rays. It's not an expensive machine. Let's make it available in every region, every divisional hospital where women can get a mammogram. Then the second problem always pops out. Once you have positive results, what do you do with it? Let's train these advanced practitioners locally, not on every technique, but how to do biopsies. How can we reinforce our pathology department to be able to identify this and stain them? Let's get centers of excellence where we can stain for IHC and simply report it. The next thing that came up was, how do we train? What do we do with these breast cancers? Do we have surgeons that can operate it? It became a whole next problem of getting surgeons trained or even getting advanced practitioners trained on doing lumpectomy and mastectomy, which in many places you can actually subspecialize certain doctors just to be able to do that particular technique. And a lot of them have open radiation oncology centers that are functional. Others that cannot do that have opted for mastectomy rather than lumpectomy in helping these patients out. Rwanda is a good example. Kenya is a good example where you have a lot of intermediate practices. Most countries in East Africa are doing a good job. We need to learn from this. Cancer care is interdisciplinary. Now, a lot of them have had, and if you want to have a cancer treatment center, it should be holistic. What does that word mean? L'Hôpital Général does not have a holistic cancer treatment center. Their radiation oncology is not working. They don't even have subspecialties in multiple cancers that can be treated. So they are not a holistic cancer center at all. They don't, majority of the nurses, they are not trained oncology nurses. They are not able, if the doctors are not there, identify patients who have side effects that they cannot continue treatment. So majority of those patients would die from side effects rather than from the cancer itself. When you give toxic drugs like chemotherapy, our drugs are very toxic and they need continuous monitoring, Brian. So I think I would go back. Prevention is always better than cure in Africa. At this moment, we can always get to advanced cancer care, getting PET scans, which we don't have, getting MRIs available, CT scans, but you cannot equip hospitals with multiple MRIs when you're unable to equip them with a simple mammogram, an ultrasound, an EKG machine. Do you know, during COVID, I found out that there was like 2 EKG machines in L'Hôpital General. Maybe there are other places that were hiding somewhere, but I know of someone who works there who was looking for an EKG machine for them to do an EKG for their loved ones. It just tells you that those who control the hospitals need a little bit of reawakening too.
Thank you so much, Munoh. Dr. Dieter, welcome once more.
Yes, sir. To start with, thank you, Munoh, for the presentation. As you rightly pointed out at the beginning of your talk, you were going to be very critical. And I thought you did a very good job in that perspective. However, you know, when I listened to this talk today, apart from, you know, discussing breast cancer as a real public health burden all around the world, but the way it's handled in Cameroon, a lot of questions arise from your presentation. You know, previously we've talked about the role of the town hall, of the Cameroon town hall, where we are right now, and how we can impact policy or change in Cameroon. Because what is going through my mind is the fact that we come here now and we outline these problems. The training is not there. The resources for basic mammogram and x-rays to do mammograms are not there. You know, we talk among ourselves, we chat here and then we close here and we go home. One of the most important things that I think we as a town hall can do is, how does this information get to the authorities who can affect policy change? Otherwise, next year during the cancer month, we will come back here again and say the same thing. I know recently the minister created a committee, the diaspora and home branches, how they can work together to affect policy. Is this something that should be going through that forum so that we can get the change that we need? I hope nobody walks away from here today thinking that, you know, those in the diaspora are here to criticize. Of course, it's painful when you watch a system, Cameroon, for example, not able to do the basics that are required. If you cannot do ER or PR or HER2 testing, we can at least screen. We can screen. If we can't do that, how can we even blame them that they cannot do ER or PR testing? So we said it before you gave the presentation, that the focus in developing countries is prevention. If anybody is thinking that treatment will be the way out of all this stuff, we are lying to ourselves. We are just not there. And you outlined it in your presentation. But as the chairman of this team, as somebody that collaborates with the minister and is on that committee that was formed, how can we channel these real concerns, things that affect people's lives, life and death issues, to the authorities that can affect policy, that can change the way cancer care will be in Cameroon going forward? We can discuss this in any other aspect of her. So I think that's a real question for the town hall to ponder on and come out with a strategy, how we do not only do the talking here,
but how we can do the work and bring the change to the people that need it. Thank you.
Wow, thank you very much for that very thought-provoking question, which I think it's the goal is not just to criticize, but to be able to find solutions. I've always said at the committee, the goal, the reason why I am there, and I want to also acknowledge things that have been changing in Cameroon. Recently, I think mammograms were offered to a lot of the regional hospitals. And we had brought this up to the minister personally about access to screening for breast cancer. I know Bamenda Regional Hospital just had a mammogram machine. I don't know if they have set it up for it to work. They just had a mammogram machine. There are other regional hospitals, the delegates can tell us the ones that acquired it. And it's a policy which we have tried to advocate and will keep advocating. The policy is going to be at different levels, where we advocate to make sure that we are able to screen first for all important cancers. I am truly in Cameroon advocating cervical cancer should be done, there should be access to cervical cancer screening and vaccination. Mammograms should be available in all regions, which I think we are getting there soon. It's important but we need policy in place in those hospitals for those mammograms to be cheap, affordable, or even free. And we need these doctors in training, which is discussions that in these committees we're going to have, where our general practitioners, their training, emphasis is laid on prevention so they know, because if you have a mammogram machine and it has been available in multiple hospitals, but none of us even send patients there because we didn't even know the guidelines. And we're not aware of this. So I think your proposal is something which, as a town hall and in this committee, we're going to try as much as possible to bring up all cancers, not only breast cancers, those that we can prevent, make sure that we have investment in healthcare that is going to provide a cost-effective way of diagnosing them early and preventing us from actually getting patients late, which our healthcare system cannot handle. So I will take your recommendations and insist on them also. I don't want to be talking only for cancer in these groups, but I will try as much as possible. So prevention is really better than cure. Advocate also for training in Cameroon. The Ministry of Health does not deal with training. It's done by the Ministry of Higher Education. And it becomes very complex because you see the decisions they make. I'm being critical today. I love to talk about solutions, but at times in Cameroon, you need to be critical so people hear you. And in all these meetings, I'm always very critical. I say what I believe in, especially what is evidence-based. If I find myself, the best way is to find yourself where policy is made and you tell them what happens. The first time in my life when I found myself in the US, I found myself in the Women Delivery Conference. Hillary Clinton was there, everybody was there, I put up my hand. And that made change in Cameroon. I was there with Dr. Efwe Valerie. What we said was that we do not want the CDC, the money for HIV to be going to the Baptist mission because they don't cover all of Cameroon. It should go to the government despite them being corrupt. If they really want change, they should be able to hold our government accountable, but the government has access to healthcare in Cameroon. You can't give it to someone who doesn't have access to all healthcare. So when I find myself in any forum where I think those who make decisions are there, I try to advocate for the right things, and we're going to do that. And I would urge everyone who is in those forums to be able to advocate for things that would cause change in Cameroon. Yeah. I see Elvis unmuted himself. He has something to add. So
Yeah. Thanks, Munoh. And that's a very important question that our big brother Ivo asked. And as a town hall, rightly, our objective is to see how we can really help the ministry to get some of these policies in place, or also those that are in place to make them really functional. I have the opportunity to always really try to read the Eco Santé news of Cameroon and try to know what is happening. So I keep pace with what we have as conversations here, because honestly, for the past 3 years that the town hall has been existing, we've covered almost every topic that are essential to the healthcare system of Cameroon. We've had people come here to address different topics. And for each of those topics, I always take note because I always do the summaries of some of the key issues so that whenever I see Eco Santé news, I want to see if this can be in line with what we discussed, or if this somebody somewhere heard it and try to solve a problem somewhere. So last week, when I saw that the L'Hôpital La Cantine had acquired their first ever pacemaker, I was happy because I remember we had a cardiovascular surgeon here who had the serious conversation with us about just enough of some of those things that we are lacking that we needed to have as basic things. So what we should do is being able to keep track on some of those things that are happening in Cameroon with vis-a-vis some of the presentations that we are having here, so that we can also be able to see what effort is being made, but also try to hold them accountable for some of those things that were promised but that are not yet done. But the good news is that the committee that was created by the minister is really a serious one, with very serious representative like Munoh, like Dr. Munoh and Dr. Samuel. And I think that our voices are being heard. We should keep on saying it the way Munoh is saying it. We should keep on, pointing out those things that are wrong, but we should also try to find some little space to acknowledge those things that are being done, so we can encourage them to do more. I got feedback that I think that was from the committee, that the Minister of Health wants to come back and give us a kind of a report card of what has been done ever since he was here to talk about universal health and what is happening and some of the updates that has happened in the ministry. If he is comfortable coming to sit here and talk to us what he's doing, then we should bring him here more often. So I hand it over to the chair to say, if you can bring him here the third time, I think we can be able to scrutinize and still grill him a little bit and point out some of these issues. Thanks.
Yeah, Elvis, thank you. And I think we are lucky to have a minister who is ready to talk to the people, who is ready to listen, and truly ready to listen to some of these proposals that we have, because it's easy for anyone to criticize. But I always say the real constructive criticism is when you criticize and you have solutions. As we said, this problem has solutions. And Ivo said in the beginning, Dr. Dieter, that we can easily restructure our healthcare system with the existing structure in place, just to lay emphasis on different cancers that have high burden in Cameroon and be able to screen these patients, get them diagnosed early and provide treatment. We can do that. The government is putting some effort, which I know, and trying to get access to mammograms in all regional hospitals. And I think from there, they're going to move to also divisional hospitals in the different divisions. And if we can get to that point where we can screen, that would be excellent. And if we can keep talking and not staying quiet about the things that need to improve in healthcare. So Elvis, bringing the minister back here, we're going to try that. I would warn the minister, he is very willing to come to the town hall at any time. So we'll see how we can bring him back so that we can talk about other aspects, especially universal healthcare, because healthcare is huge. I'm concentrating today on breast cancer, which is just a tiny part of healthcare in Cameroon, or a tiny health problem, but Cameroon has bigger problems. But this is not a problem that I think should be neglected.
Thank you so much, Munoh and Elvis, for all the discussion. So before I get to you, Dr. David Oko, just since, Munoh, you talked about screening and guidelines, and it's also important to note that the Ministry of Public Health still, I think it's still responsible for the training of specialist nurses in Cameroon, in that specialist school in Yaoundé. And I was just looking for the list of the different specialist trainees that came out yesterday. Unfortunately, I did not find, just to find out the list of the different specialties that are in that school at the moment. That list has been expanding, and it will be very interesting to see whether at some point oncology nurses can be trained in that particular institution. And just to ask you a question on screening. So during your presentation, you said I think in the US, people above 50 or women above 50 are required to get a mammogram. I think in the UK, I think that age limit is the same, except Judwin says otherwise. What of Cameroon and Africa? I'm saying this for two reasons. If we have to screen, at what age should we start screening, Munoh? Should we wait till 50? Meanwhile, our sisters are getting cancers at a younger age. When should we start screening? And probably, I don't know if we have strong, observational data to support a particular age to start screening. I just want to hear your thoughts on that.
Very interesting question. This is the biggest debate in medicine in breast cancer is screening, when to start screening. So in the US, I am part of the American Cancer Society. We start screening at 40, okay? We are stubborn. We start screening at 40 and we do it every year. And at the age of 55, we do it biannually, once every 2 years. So, but we start at 40, that's our recommendation. It's based on evidence and some weak evidence. But the United States Preventive Task Force, which is responsible for all preventive medicine, is usually late because they take into consideration not only screening, they take into consideration cost effectiveness. So they don't look at data only in the sense of, does it help? What is the cost effectiveness of the whatever you're doing? It's just like the American Gastroenterology Society had decided 45 long ago for screening for colon cancer. The task force just adopted it recently. The task force looks at how much money are we putting in screening all of these people? Are we gaining anything from doing that? So the task force actually recommends in the US screening from the age of 50, and they recommend biannually to the age of 75. If the woman has a life expectancy greater than 5 years, then you continue screening to death. In other countries, like in the UK, usually screening is at 50 biannually. UK, Australia, Canada is 50 biannually, and WHO recommends screening biannually and starting at the age of 50. And I think that is what Cameroon should adopt because we don't have our data. Dr. Motaze made it very clear. We are a desert data zone. Little or no data. We have a cancer registry which is full of retrospective intakes, just mostly cases from Baptist Convention and the cancer center in Yaoundé, which is not actually a cancer center. So those data are very biased. You cannot use them to make any kind of decision about screening. Now going to breast cancer, there's something in medicine where you know about different kinds of biases. Each time we have a young person who has cancer, we know about it. Everyone talks about it. Everyone is so interested about it, and those are the cases that stay in our minds. And we have young women who are diagnosed with breast cancer. Is it overwhelming compared to the rest of the world? We don't know that because we have not done data. We have not studied. You are a primary researcher, and I think that is data we need to analyze. Why? In the US, we know that Black women have less breast cancer than white women, but Black women die more from breast cancer. We have a higher mortality from breast cancer. It could be as a result of access to healthcare. It could also be as a result of us having more severe breast cancer. We tend to have more triple negative breast cancer, especially when women are younger, when they are pregnant. So you can have cancer with pregnancy. Most breast cancer with pregnancy is actually, it's one of those places where we meet a lot of triple negative breast cancer, sadly. But you can still get estrogen and progesterone breast cancer. But for Black women, it becomes very complicated because we have a lot of dense breasts. We actually need MRI more than our white colleagues. We don't even have MRIs, but we also do not have data to know how many families in Africa are having BRCA genes. Most of us don't even know whether our grandparents died of whatever disease. We don't have anything. We don't know how many of them have Leaf-Framini. I told you I've met 3 Cameroonians in the US here who were diagnosed with Leaf-Framini. You cannot believe it because we don't test. If you don't test for something, you're not going to see it. The BRCA gene was found first in Ashkenazi Jews, but it doesn't stay there. We have seen that a lot of Black population does have it. A lot of Black populations do have other genes that we know of. We have data now. Leaf framini is common in Black populations. Cowden gene, I've seen it. PAB2, I've seen a lot. CDH1, I've seen a lot, but BRCA also, we have seen a lot of it. So the Black population in itself in the US is classified as a high-risk population because they tend to have more aggressive cancer. So we need data. I'll go back to, we cannot talk when we don't have data. Research should be one of the big priorities that we should have going forward.
Thank you so much, Munoh, for that answer. Dr. Oku, over to you, please.
And before Dr. Oku, I'd like him to just say where he's called dialing in from. He's one of our fervent participants from Ivory Coast, and he's a geneticist, and he's just so much interested in the Cameroon Town Hall. And each time I like to highlight his presence. Thank you for taking interest, Dr. Oku.
It is a pleasure. I am currently in Abidjan.
Yeah.
So yeah, I'm dialing in from Abidjan. And I want to thank Munoh for his presentation. It's always a pleasure to come back to this platform, and every time Munoh has information, I learn from him, whether it is on this platform or on his WhatsApp feed. He doesn't know that I track him. But I'm being curious, and prevention speaks to me as a clinical molecular geneticist. And you mentioned some genes and all that. And I've been here trying to have answer to some questions. And the literature will usually say that anywhere from 5 to 10% of cancer is hereditary. But we know at the same time that most of the biomedical studies are European-centric. African population participate at like max 2% level. And you just mentioned that the disease course is more severe in Black women. And given that we have a high genetic diversity and the level of variation that we have, my gut feeling, and I don't have any data to prove that, tend to think that the genetic contribution to cancer may be at a higher end of the spectrum of that 5 to 10% when it comes to hereditary contribution, and maybe a little higher if we add familial contribution. But what I wanted to know in the context of Cameroon is to know if anyone has maybe studied multiplex family or family with family history, like heavy family history, because there's a clear genetic algorithm, genetic testing guideline for breast cancer that take into account like first degree relatives, second degree, third degree, with the pedigree really being used as a first line to determine transmission and establish medical necessity. So what's the state of the hereditary side of breast cancer, given the diversity and all those variations that no one has been able to capture yet?
Yeah, that's a very important question because we do, to my knowledge, we do not have that data.
Wow.
Or we may have genetic studies without doing any gene analysis for breast cancer. And that is a field where research is needed, a field where we need dying research right now. Why? Because we've had a lot of sporadic cases. I know more than most of the young breast cancers that have been presented to me in the past 5 years. I've had more than 15. More than 15 of girls who are younger than 40. I don't want to get anybody out of the day, but I know many. And I know some in the US where genetic testing was negative. And it's very important that there are times that in genetic tests, you know very well that there are genes of uncertain significance. We don't know what they are right now, but we may know later on, because Africa has the highest human diversity in the world. Our gene pool is more diverse than any other genetic pool in the world. That's why we have difficulties in getting bone marrow transplant. And we are getting to realize that almost all cancers, there will be a big presentation in ASCO this year in multiple myeloma, which is going to be ground shattering. It may prove that Africans don't even benefit from bone marrow transplant. Why do we transplant them even in the first place? It may prove that we don't, just the genetic pools, we have been, a lot of studies, as you said, have had Africans as minorities or not even included in these studies, or African Americans. When we do subgroup analysis, now that we're including them, we're finding out a lot of therapies that we have in place account for the high mortality because they don't even benefit from those therapies. We are getting evidence in oncology about that. In multiple cancers, not one or two, multiple myeloma be the one. So African Americans tend to have multiple myeloma more and than the regular Caucasians, but they tend to do well. But because of access to healthcare, they don't do well, but there are some particular treatment that do not work well. Most cases when I was in New York of triple negative breast cancer that I saw were in African Americans in my practice. We saw more African Americans. It was an empirical data that was striking me on the face, because all the young girls who came in less than 40 years, even when I did genetic testing, they were not positive for BRCA. You could see that they were all African Americans. I remember a lot of them by name, even those who have passed away. We lack access. Even in the US, there's an issue of access that explains partially mortality, but there is also a genetic component that we need. We are still scratching the tip of the icebergs of genetics and precision medicine. Oncology is leading the way 1,000 years ahead of every other specialty in precision medicine. That is a fact. I'm not abusing any other specialty. But oncology is 1,000 years ahead of other specialties that are catching up in terms of precision medicine. And we are coming to realize that the genes are important for us to target cancers, for us to be able to understand even why people have certain diseases. I'll tell you, I've had 2 Cameroonians in the US who have been diagnosed with Lee Framini. They could not even believe that in their generations they had cancer, but they knew of a grandparent who died of abdominal pain. Most likely it was a GI cancer, nobody tested. They knew of one family member who also died of, they said, the kidney. So all those things that were happening, people did not diagnose them accurately. But I know 2 girls who had Lee Framini. It's strange that you could know just 10 patients with cancer, but I know 2 with Lee Framini. 2. Okay. Genetic testing, Lee Framini positive, P53, Cameroonians. But in Cameroon itself, access to genetic testing, NGS, is still rudimentary, not available. We have some research from Alliance Française. We have research from others that are doing, but they are more in infectious diseases. That's where sponsoring is going on. Nobody is sponsoring any kind of huge cancer care in that aspect. That is why I would go back to Dr. Motaze's point for us to always put research first if we can. And we would need your help if those who can collaborate with you. You're an eminent professor in genetics from Emory, and you can always help us out too. If those who want to collaborate, we have students in the platform who want to do something and look for funding.
Yeah, and Munoh, I think what you just said, and I'd like to come back to Dr. Okudavid, who has a solution. Can you just tell us where you are and what effort you are making to scale up your solution in Africa for as far as genetic screening is concerned? And how can Cameroon benefit from it?
Yeah, so before I get to the answer of that question, I'm going to share a little bit about it. Data that I have, it could be preliminary, but the first thing that I noticed when I got here with the intention to transition from a study on African American to a study of West African, because we had a founded population. of the African American, is that I find it that the physician here, the primary care physician, even in the specialists in oncology, had a hard time asking the proper question to identify patients that were eligible for genetic counseling and maybe subsequent genetic testing later. And when I understood that, I formulated a series of questions for them to understand, and I sent it to the director of the national the program in the fight against cancer, the Programme National de Lutte contre le Cancer. And 2 days after, he sent me a list of 78 women. My first reaction was to go to the age column. The mean age was 28, all breast cancer with a lot of family history. And I started testing some, and what I realized, I find a lot of mutation in BRCA1, BRCA2, but they are VUS, which means that we don't have enough data to decide whether they are pathogenic or not. It could be, it could not be. And it's really suspenseful for the physician to tell someone, we don't know, we have to follow, we may get back as the data get updated. But in cases like that, it is my responsibility when I see multiple times the frequency goes up to reclassify inpatient, if I see inpatient who are sick. So back to Elvis's question, I've been here, I have a cancer panel that I'm offering. It has 84 genes, and it's a multi-cancer panel. So obviously that includes breast cancer, colon, uterus, pancreas, and things like that. And it has been helpful because the level of family relatedness and identifying subject that needs to be tested from the proband, I had no idea that the hereditary part could be that important in this context. We mentioned 5 to 10%, and now my question is, that 5 to 10%, will it be confirmed? Will it be on the lower end, on the higher end? But it looks like it's going to vary on the spectrum, given what Munoh said about the highest level of genetic diversity that we have yet to capture. 2 major studies have already told us that we are just scratching the surface, as he said. One that mentioned that 10% of our DNA is missing in a reference genome, and another one that says 3 million variants in African have never been seen in a human genome. So when we now ask the question, how many African, multi-ethnic, multi-geographic, should we fully sequence to capture the level of diversity? We are around 3 million right now, and it has not started. So there's a lot to uncover. And as a scientist, science is a team sport. I am open to collaboration. I was privileged enough to be featured in the show Sous la Lumière from Robert Braza. Yeah. And I've been receiving phone calls from different places. And I'm gearing up to start research. And thank God, Emory understood that. And they still kept my appointment, even though I told them I'm going to be here. I'm working in 2 time zones, which is not easy. But it is really a blessing to be in that position to help.
Wow. So I think we just need to collaborate and try to figure out what is going on with us Africans. As you made mention of, we are having a genetic pool that has not been well studied, and there is a lot to unfold.
Yes.
Even in the Human Genome Project, we're not represented adequately.
No.
The good thing right now is that the NIH has seen this. Those big funders have a priority given to Africans to be included in all clinical trials, in oncology. So we're getting, and part of the problem in the US is even training doctors who are Africans.
Yes.
African America represents 15% to 20% of the population, but represent 5% of physicians. I see the difference in my patients' faces when they come in and realize I'm Black. It makes a lot of a difference. You can't believe it, especially my breast cancer patients. They, after seeing me, most of the time they agree to every other treatment. It makes a whole lot of a difference to be treated by someone who looks like you, no matter how you want to put it. I think if there, after Dr. Ambe, Makate, if you can take some of the questions and there are some things I want to address.
Yeah.
So I decided this was going to be a critical presentation. And I did not say we are not doing ER and PR in Cameroon. We're doing it in one place. I know that very well. The rest of it is sent abroad. I have tracked cancer in Cameroon for long, and I want to ask those who are responsible for healthcare in Cameroon, what is stopping each center in Cameroon from doing an immunohistochemistry, those who run regional hospitals from investing in their pathology departments to be able to do histoimmunochemistry? Why should it only be Central Pasteur doing it? And you need doctors who are knowledgeable to even send it. I know the Baptists, I have done this. Some people may think I worked in Cameroon for many years. I trained in Cameroon in clinical pathology, and I have been involved. And before saying this is because I found out that multiple pathologists that were sent to me to help did not have the ER and PR status on them. How do you help patients when they do not have that status on them? And as I said earlier, if you want to understand breast cancer as a medical oncologist, you cannot treat any form of breast cancer if you don't have that information. You would give inadequate chemotherapy to many people, and you would turn to kill patients than help them. And that is why throughout my advocacy in Cameroon, I have not done for treatment. It should be emphasized on histoimmunochemistry. If you had a poor pathology department, they may sound like they are doing a big job, but they are not. What is important is the quality of what you produce. I have read 80% of those pathologies and I was dissatisfied, not because, even if I'm back in Cameroon today, I'll still be dissatisfied. It should be reflex that every breast cancer should have an ER-PR state. I went to Lacantini Tumor Board and they told me it's because it's expensive. I asked the question, how much is your chemotherapy regimen? It's about 500 to $1 million. Why do you give chemotherapy to someone who doesn't need it or who may not need it in the first place? Why are you giving chemotherapy to this woman? Tell me why, because if you want to tell me the guidelines, why are you giving chemotherapy where we know that about 70% to 80% of breast cancer in Nigeria, in Ghana, are all ER-PR positive? And all the ones I've asked for in Cameroon, which were done, came back ER-PR positive. Why are you giving chemotherapy in the first place if it's not a financial, because there's a lot of financial gain behind some of these things. And doctors are not well paid. And doctors want to do treatments that they will benefit from if they're in the private too. These are things that people don't want to talk about. Some of them may not even be lack of knowledge. Some of them may just feel that that data is not going to affect them. But this is something which is sensitive. If there is one message I want to pass across to all those who are in the forum, especially those who treat breast cancer patients, please, for all your breast cancer patients, the gynecologists in Bamenda are doing that routinely now. Ask for your ER-PR status before you do anything on that patient. If it's lacking, you can start treatment abruptly, but this is a message I really need to emphasize on, because we have had patients who have had double mastectomies who had metastatic disease. There is data since 1960 that surgery does not improve mortality in those who have metastatic disease. It's clear, it's written in stone, and that radical mastectomy does not improve survival. This is Trostadian studies. This is 18th century knowledge. There is data that shows that if you treat patients who are ER-PR positive with chemotherapy when they don't need it, you are doing harm than doing good. It is clear data. So if people are still practicing that, and if I have a young girl in Cameroon, why should I not get emotional? Who dies at breast cancer and I'm trying to get the ERPR state and has gone to La Cantini, l'Hôpital Général, but nobody requested for the pathology to do an ERPR state, was on chemotherapy and the ERPR state comes back to be 100%. Why this girl would have been on exemestane, anastrozole, letrozole, and lived for about 10 years? Why should we keep encouraging mediocrity? So I would, Brian, you can go to the next series of questions.
Yeah, sure. I think you've pointed a lot of things, and I just wanted to say that Dr. Eko had questioned your perspective whether American screening guidelines should be directly applied in the—
No, and I said in my presentation, no. It was clearly no, because my presentation was very clear. It is no. Why? Because the guidelines in the US for us to screen, WHO has guidelines which I presented, for us to screen from the age of 40 is because we are a wealthier country, we can do that. And we can screen every year. And that is why, and that is advocated by the American Oncology Association. This task force doesn't even acknowledge that. The task force wants screening from the age of 50 with WHO every other year to the age of 75. And that should be what Cameroon should adopt because it's more cost effective. You will miss some cancer patients. As I told you, there is a trend in Cameroon, as Dr. David said, Oku, where you have younger patients less than 40, sporadic cases of cancers occurring. In that case, that's why I said in my presentation again, physical exams and breast examination should be allowed in Africa. Why? Because that is how most cases are diagnosed. That is how women less than the age of 40 tend to know they have cancers. In the US, why is it not encouraged? There is data, which that's not what I'm advocating for Africa. If you're doing mammograms every day to everyone, why should you be telling them to do breast exams? Your hands, I will tell you this is evidence. Your hands will never be as accurate as catching early stage breast cancer in someone who gets mammograms every year. So self-breast examination in the office in the US, it's useless. In Africa, there is evidence. In underdeveloped countries, there is evidence that is how we get to diagnose most of our cancers.
Yeah, sure. Yeah, thanks a lot, Munoh, for responding to that. And I'm glad that Dr. Eko is here, and I think he would have the opportunity to talk about it. But just before I pass it on, I think, and thanks again, Dr. David Oko, for your work and also working on really expanding the genetic diversity pool across Africa. I think the 3 million, you said 3 million, if I'm not mistaken, cases would be, I think that's quite a huge number, and I think it's definitely going to be very difficult, but I'm really hopeful that we have representative sampling across the continent that will really capture the wide genetic diversity that we see across the continent. But also really interested if it's possible for you to extend your panel of 84 biomarkers that you mentioned, if there's any possibility to make those locally available in Cameroon, if there's some way that that we can establish a partnership to enable those markers from being available. I heard Dr. Munoh talk about 2 Cameroonians that he has seen with Foma syndrome, which is a genetic marker that increases predisposition for different kinds of cancer. So I think if we have biomarkers that can help to detect some of these things early on, I think that could have a significant impact. I don't know if Centre Pasteur, for instance, has access to your panel, but I think it would be great if that kind of public-private partnership is established to facilitate those diagnostics, Dr. Oko.
Yes, thanks. So the panel is a set of genes that have been well curated, known in the literature to contribute to providing susceptibility to cancer. And so those have been tested and proven to assess the heredity form of the cancer. And yeah, as far as collaboration, it should be easy. Obviously, I'm based here in Abidjan, in Côte d'Ivoire. So the good thing is that the samples that I work with for the cancer panel, cardiovascular panel, neurodevelopmental order, all these are all buccal swab, right? So buccal swab are very stable at room temp. They can travel easily through the company, whether it's FedEx or DHL. And yeah, so I guess the most important part is to discuss collaboration, whether there's a collection point, who's involved and what are the needs, and then I can probably send all the collection kits with all the instruction and what needs to be done, all the test requisition form, things like that. Then we can discuss help. And it's not just today we are discussing breast cancer, but my work extends outside of that. Even simple paternity testing in Côte d'Ivoire is not done in the country. It goes outside of the country. I mean, we have a lot to cover, right? So it is, it's a lot, but I'm here, I'm available, and I have this concern that we need to really contribute data of African to the scientific community so they can know how to better take care of us, whether it's in Africa or outside Africa.
Yeah, so it's a call in the house for anybody who is home in Cameroon and who wants to collaborate with Dr. David Oku. We can provide his contact to you, and you can reach out to him and see how to take that forward.
Thank you. Thank you, Elvis. I would like to pass it on to Dr. Eko. Please, Dr. Ambe, just 1 second. I know Dr. Eko's hand was up, and I really would like to welcome his thoughts as well. So, Dr. Eko, please.
Yeah, thank you very much. Good day to everybody. I don't know, morning, afternoon, evening. Sincerely, I'm happy to be part of this discussion today. Firstly, being a policy implementer as a regional delegate, but again, as an obstetrician gynecologist for about 15 years. I really appreciate the presentation. At least I've made some comments in the comment session, but I sincerely wish to appreciate the presenter, Dr. Munoh. It's a very good presentation. I don't want to be long. There are many, many things that I heard I would have liked to talk on, but I don't want to be long. I want to be very short and very brief. First, I want to say, yes, you mentioned so many times you've been very critical, and I felt it too much. Not that what you're saying is not correct. There are many things that you're saying that are correct, but in your presentations, you're giving the problems. And the problems are there. And if you have identified the problems, then it's from the problem that you need to look for solutions. You've mentioned of the mediocre treatment of our doctors, of our nurses. You've mentioned the plateau technique of our different hospitals. You've mentioned the training of our personnel. Not only that, I want to make you also understand that most of even those who are presenting faces of being specialists, I don't know where they did their specialty. But again, the quality of results, you just talked about the pathology results that you receive. Of course, those are the problems that we have internally. I want to tell you that personally, I have stopped about 4 or 5 patients who were to go on surgery for breast tumors, for breast masses, because the immunohistochemistry was not done. And I had to send to Centre Pasteur, of course, Centre Pasteur, because it is subvented. That's the only laboratory that does it with subvention from the state. So obviously their prices are lesser. In Centre Pasteur, it's about 100,000 francs, which is subvented. Meanwhile, you go to a private lab. There are private labs that I don't know whether they do locally. You see they send abroad. I don't know. It's about 250,000. So it becomes a problem. And I think we should look forward. What do we do? Because we'll continue to criticize and we'll move nowhere. What do we do? You people are over there, of course. As I say, all of we have remained here with the treatment that we receive. A doctor of my caliber, 25 years of service, I earn 350,000. If I maintain that salary, I will not live in Cameroon. I'll also fly abroad and stay abroad and maybe get my training there, live well and talk. Please, I don't want to be as critical as you've been, because if I want to start attacking critically, I will do. What I will just advise now is, what do you people who are there with all this knowledge, with all this exposure, how can you come with us to see that some of these problems that you have identified, which I totally agree, can be looked into for us to come out from this mess? We have our congresses, the Congress of the Society of Obstetrician and Gynecology. We, as of now, we don't have a standard of care that is put by the professional society, especially that of obstetrician and gynecologists. Of course, we are just working on that. But we have Congress, and in Congresses, we have pre-Congress workshops. Why can't you people who are there with all this talent liaise with us on a Congress like this? You take 2 or 3 days for a pre-Congress workshop, sponsored, and you come and you just said of doing biopsy. Come and do a small workshop on how we can do cone biopsy for those who want to do it. Come and do for how we can, I don't know, anything that you've seen that is, I do agree. Sincerely, there are so many things that I've heard. I will not want to take the whole time, but I think just what I've said, you understand exactly what I mean. And because you have always come to our help, I want to appreciate, as I appreciated the other time, the cholera assistance that you gave us for us to come up on some of these issues. So please, just think about it. You can work with us. Next year, we have our Congress. We can do a pre-Congress workshop on a specific aspect on cancer diagnosis, on cancer management, and so on. And of course, it will help us locally and will train persons. We cannot force a nurse to do a training on oncology nursing. You know, when they do publicity of these things, you choose the one that you want to go, and people go and do the courses that will give them fast money. They don't do a course that they will go and they will have social cases that they will only be removing their money. They want to do a course that will give them fast money. And you know that very well because you also identify that problem. So sincerely, please, you have this expertise. Please with us, and let us see how we can do better in our country. Thank you very much.
Yeah, thank you very much. And as I would say, Dr. Eko has been a big brother. During my residency, during my medical training, he was training fellowship in residency, helped us throughout. He has been supportive and he's been very protective of Cameroon. And also solution guided, which is something I love a lot. When I started this presentation, I said this was going to be one of the presentations I would be very critical. And the reason I decided to be critical is that I just wanted to break some comfort zone discussions and get out of that comfort zone so we can talk about certain things. Because there are times when we need to really get out of our comfort zone and understand what is happening. And Dr. Eko, I agree totally. And that is why I'm trying to get other partners, especially in oncology, who are Cameroonians, who can actually contribute back home. And that is why I partnered with the Northwest region, and they have been doing, with my help or without my help, they have been doing a wonderful job. Excellent physicians doing a wonderful job with all their cancer patients. We have tumor boards as frequently as we can. I also joined La Cantini tumor board, but there it was so chaotic that I could not even give my input. But there are times that we need to be able to tell people that there are certain things, because even in La Cantini, it was, to me, when I brought it up about the IAC, they told me their oncologists have never insisted on that. So if you get a platform in Cameroon, I investigated about IHC and I found out that everything in most private labs are done abroad, either in France or in the US. They are sent abroad. That's why it takes 3 months, or Central Pasteur. My question was a basic question. Why could those things not be invested and let's do them back home? What are we lacking? Is it that we are lacking investment in pathology? Is it that we are lacking in training, or we are lacking. Those who are pathologists are not advocating for the right thing. So that is really one of those places I want, because if we start at the level, oncology can never be mature without a good pathology department. Never be mature. I attended the tumor board in La Cantini. What I found out was that the pathologists came as the bosses to ask other people questions. But in tumor boards, everybody comes with questions to ask pathology. Radiation oncology, radiology wants to know certain things. But in that case, pathology was not actually presenting anything. They were just sitting there and asking other people questions that were like they were in the medical school. That's not the goal of a tumor board. The goal of a tumor board is to question what is the exact pathology? Why? What can we do next in order to know what is really wrong with this patient? Do we need extra imaging? Do we need, and I told them that this is how tumor boards are organized. And I would love to invite them to my tumor board so they get to know. Some people were very angry, but I think you need to be able to tell people. There was a specific case that was presented, and someone was asking the surgeon, est-ce qu'on fait une scanner pour quelqu'un qui a une diverticulite? I asked, what is important? This guy already has colon cancer with mets to the liver. That's what we should be talking about. Can we do a metastatectomy? Are we able? Why are you questioning this surgeon because he was your junior in school about whether he should do a CT scan for diverticulitis? That's not even the environment to do that. We tend to misplace environments of where we can put our powers on other junior doctors. The goal of a tumor board is to center around a patient, understand what his cancer is, what stage is it, what is the best treatment outcome. Can we get help from surgeons, gynecologists? Can we get help from hepatobiliary surgeons? Can we get help from radiation oncology? What can they offer? Is there a special staining that is not done by pathology that pathology can help us with? But I found out that these tumor boards were meant for people who would ask questions in their area of specialty where they are comfortable to others, which are irrelevant for patient management. Especially when I attended La Cantini, it was, I don't want to say this, but it was my professors who were there, but I was...
Thank you very much, Dr. Munoh. Sorry to interrupt. At this point in time, we have just a few minutes to wrap up, and we have Dr. Ambe, whose hands has been up, and we're going to get Dr. Ambe, and then afterward, we can get Dr. Eroy, and then we can see how to wrap up the session. We are already 3:32. It's only when the topic is as interesting as this one that we can stay here up to more than 2 hours, 30 minutes. And that's only because we have someone like Munoh who can keep more than 50 people online and many on Facebook online up to this time. So thank you so much for your excellent presentation, one of the rare sessions we've had. So I hand it over to Dr. Ambe.
In fact, thank you so much, Dr. Munoh. You've said everything, you've presented everything. And there's very little I have to contribute here because I've spent more time rather learning. But I also want to thank Dr. David Oko, whom I've sent him my contacts, that we are together here in Atlanta. I just told him I'm an immunologist, molecular biologist, and I also have a private research, genetic research here in Lawrenceville, just starting. So when you come back, please, let's have coffee sometime. And then we'll talk more about some of the things. Probably Dr. Munoh and others could send some of those samples and we can look at them together. Yeah. Thank you so much for your contribution. Dr. Munoh, you've been so excellent. I mean, I want to assure you that the paradigm is going to change, and rather than taking these solutions to other people to handle them, what if you all sitting here, you'll be the ones to handle them? So I just want to encourage you to keep this stream running. Why do I say so? It's because the way I worked with the late Professor Ngu was because he was in one of these kind of fora, and the president then, the president before the current president, thought that he should go around the world and meet you know, the brains and bring them back to the country to help the country, which is exactly what the Nigerian president today is doing. He is moving around from country to country and meeting the brains to bring them back to the country. I'm not speaking for the country. I'm just speaking as somebody who knows history. And so I'm learning from history to encourage you that this multidisciplinary approach that you're bringing here, I pray that this forum will continue. And so one point I want to bring up is, have you looked at the oncogenicity, the viral oncogenicity in the patients of breast cancer patients in your setting? Given that the HIV virus has been prolonged in the systems who have successfully taken antiretrovirals, it just means that the interference with the nuclear transcription system has also been prolonged. And we know what that has to do with the cycle of, the cycle of response, of cell cycle response. That has a very significant role to play. Perhaps, I don't know, but we can find out, perhaps that's why the Black population may be, a high risk, because of also the high, we've sustained our Black population here in the United States longer on the antiretrovirals, and so the virus has stayed a little bit in us. So those are some aspects which I would love for you to you could comment on, or probably look at it in your practice to see if the viral aspect has contributed to some of the either the the incidents or the response to treatment in some of the cases, specific cases. The second thing is, you have well brought up a wonderful solution. I'm sad that things like ICH are not being done in Cameroon. It's ridiculous. And then herceptin, which is so useful, is preferred to chemotherapy. That Cameroon can have more of chemotherapy than things like trastuzumab and herceptin and so on. It is it's insane. And then it's therefore very vital that this forum should put together these results, whether they are being used or not. I really don't care if they are being used, because guess what? They may be used, but not the way you want them to be. It's just a matter of time. This country is 200 years down the line. We are just probably 50, 60 years. And so we have a lot of time. And so I really feel privileged being part of you, listening to these very intelligent discussions. And I just thought I should also share and to welcome our brother. I've not seen you much, but please try to get in touch with me once you get back to the United States.
Thanks.
Thank you very much.
Yeah, so I'll be very brief. I'll be brief so that the other questions for genetic variation, we have not studied with HIV. Atlanta may be a good place to study, but there is no data showing that HIV has increased risk of breast cancer. But that's going to be a good study to try to do it in Atlanta, because you have a lot of Black population and a lot of Black HIV population. So that's where we can do some studies. So you can link up with Dr. David Oko and see if that's some place where research can help. But so far, there is no data showing to that. Now, going into IHC in Cameroon, it's done, as I said, only in Central Pasteur. Other private labs send it out. It's expensive, but it's cheaper than chemotherapy. So do it. Don't give excuses, do it. There is no urgency in starting patient with treatment that is not going to work. So do it. The last part is giving herceptin and trastuzumab, pertuzumab, deruxtecan. There are so many. I can talk about tocatinib, neratinib. You need to give that only in HER2 positive disease. We can spend a whole day talking about breast cancer treatment. Breast cancer is truly, it's not, you don't just need to go out of the way and read it and you think you can treat it. No, that's not how it works. Treatment of breast cancer is complex. 20% of breast cancer patients are HER2 positive. And that is when we use HER2 directed treatment. but 80% of them are hormone positive. There are many drugs that are not available in Cameroon. Trastuzumab, which is Herceptin, is available, but it's super expensive. I learned the price the other day. So next question, please.
Yeah, thanks a lot, Munoh. And if the other speakers can really summarize their questions so we can round up the session. Thanks a lot for all the really helpful contribution. I want to invite Dr. Professor Weleji. It's really a really great honor to have him among us. He's a visceral surgeon from I believe from the Limbe Regional Hospital, and also a faculty member at the University of Boya, Faculty of Health Sciences. So they're in Boya as well, and has done tremendous work in many of the things that we are talking about today. And I would like to give him a chance to make some comments. You can make those brief and quick, so we can round up. Dr. Weleji.
And we always recognize heroes whenever we have them. He is a Ronald Reaven Fellow of the Royal College of Surgeons of England, 2016. So he's a very important person in our setting. You're mute. If you're speaking, maybe you have to unmute. We still can't hear you.
Oh, we are unable to hear Dr. Weleji.
Your microphone should be having an issue, Professor Weleji. Maybe
you might want to check what's using your mic, the mic setting for your, if you're using your phone or if you're using your laptop to connect, what's actually using your mic. If you can just.
Yeah, while Professor Weleji is doing that, can we get Dr. Yauba?
Sure.
So that.
Yeah. All right, thanks. Dr. Yauba, please.
Hello, can you hear me?
Yes, we can hear you, but it's an echo.
If you have two phones on, you can mute one, Dr. Yauba.
I think I would exit. I'll exit so you can use my desk. He's right there when you use. That's why it's echoing.
So greetings from New York.
Yeah, welcome.
Yeah, thanks. I think my next stop is going to be at their place, Munoh. So
we're waiting.
Yeah, please send me the ticket. And thank you for that very interesting talk. I just had like a couple of suggestions. I think one, we have also spent a lot of time studying barriers to cancer care and treatment in Cameroon. I think we have like one publication out there, and there is another one that is actually going to be out soon. So I think you have highlighted a number of important things. And one of the things I wanted to suggest is would it be possible for you to transform all these ideas into maybe a paper that we can publish? That is the first thing. And then secondly, bring out all of the important elements that you think the government of Cameroon can be doing. So we get it published in Cameroon Tribune. We can have both the French version and an English version. And I think this is particularly timely now that is how do you call it? Is it Pink October, where a lot of talks and efforts are being geared towards raising awareness against breast cancer. I think that can be like an important contribution from the part of the diaspora. So if I can have maybe a little bit of write-up from you on the problems and really what can be done to address the rising burden of cervical cancer, at least taking into consideration the new advances in technology and so on. I think that can form like a very, very nice article in Cameroon Tribune. So I can actually get that published within Cameroon Tribune. So that is it. And then I think we also need to think about the long term. Yeah, next year, what can we do? How do we like galvanize all of this effort momentum to really do something big next year? particularly during the month of October. And then we also need to start thinking about how to really instigate some sort of a global movement against breast cancer, because I know there is one against cervical cancer. So WHO has this like very big and bold strategy on how to eliminate cervical cancer, but there isn't much around breast cancer. And as you know, breast cancer is a political issue, it's a gender issue, and so on. And having that sort of a global perspective can actually help. So it will be really great or pleased to actually see that such momentum is being driven back at the Cameroon Town Hall. Over.
Wow, thank you. I don't think I need to say anything more. I just need to act at my own end. Yeah, so thank you very much, Dr. Yauba, who is President Director of Clinton Foundation and in Cameroon. So we want to thank you. I know the work you're doing with cancer, access to cancer medications in Cameroon. That I know because I've done a lot of research in Cameroon about cancer care. I get to know the price of every drug and how you're doing to improve access to chemotherapy, to targeted therapy, including Herceptin and pertuzumab, and also access to immunotherapy to start getting it available. So thanks for the wonderful job you're doing in Cameroon. And you're the right person in the platform. You're a friend, you're a brother, so I'll reach out to you and see what we can do about it. And thanks for the wonderful proposals. I think if you can get us be in Cameroon Tribune, that would be nice.
Yeah, great. No, I will, certainly. And the earlier, the better. I think now the potato is still hot, or the cake is still hot. Let's get it out there so people can eat.
Yeah. So let me
from
the moderators, Dr. Waleji or Professor Waleji, can we get still we cannot hear Professor Waleji. That's Elvis, we can't get Professor Waleji, so maybe
it's unfortunate. Everyone is anxious to hear him. It's unfortunate that we cannot hear him, but I'm sure if you follow the steps Brian gave, you might want to look, Professor, because when I look at your image in front of me, I don't see your microphone. That gives me the impression that on whatever device you are using, your microphone is not connected. So if there is a way you can, now I can see your microphone. Now, all you need to do is click on that microphone sign, and you will unmute yourself and we'll be able to hear you. So go to your microphone now. Okay, yes. But it's not giving. It's unfortunate. Maybe next time we are going to get a professor. Everyone would have been very happy to hear you, but we are unable to hear you.
Dr. Dancy, you
yes?
can click on the microphone and he'll see it. You click on his microphone, he'll see it.
Okay. All right. His microphone just disappeared.
Yeah, so I tried doing that. I tried muting him and unmuting him, but it's not still working. Okay,
okay. Now I saw the microphone, but each time he tries to unmute himself, it instead takes the microphone off. Well, we appreciate the effort. Brian, go on, please.
No, thanks. I think it was a very insightful session. I think every sessions we have with Dr. Munoh is nothing short of amazing, and nothing short of educative, nothing short of provocative. He clearly has a tremendous passion and drive to see change in Cameroon. I think that's very evident in his presentation, and also how he addresses Q&A. So this was a really great session. I hope that many of the things that we've learned today would be, we will be able to translate this into practical things, just like Dr. Zita mentioned earlier today. I think there's need for an emphasis, Elvis, for us to also really understand how policy is being made. While here at ESTM missions in Chicago, there was a session on really just understanding how Washington, D.C. operates, really understanding how Congress comes together in the US and how a bill is written and how it's actually enacted into law. So I think really understanding the steps in our local context, how policy is actually being made and what sort of data goes into that, or what sort of pieces gets into that, is really going to be crucial. So we have some practical implementations of some of the things that I think Dr. Jita talked about, and also which Dr. Yauba talked about as well, would be super helpful. Otherwise, I thought this was a really great session, and I also learned a lot. Elvis, I don't think Kate is here. Elvis?
You're very correct, Brian. I agree with you. It was such an important topic to know that we have 18.1 million new cases of breast cancer globally, and that out of this number, 5.8% is from Africa. That's very important. And Cameroon is not left out, because Munoh mentioned that breast cancer is #1 of all cancers that we have in Cameroon. So this was a very important topic. And I agree with you. We have to think about what is the journey towards policy, and how do we as a town hall find a space on this journey to be able to make sure that some of this conversation get into policy. With my little background in politics, being a politician in Cameroon before transitioning back to the United States, I know that there are some things that need to go through Parliament when it's something that the minister cannot handle. But I know a lot of bulk of these issues that we discuss on this platform are things that the minister can handle that are within his jurisdiction, right? He can create a national cancer program. He can create regional treatment centers. I just read yesterday that hepatitis C treatment in Cameroon now is free of charge. That's something that started from 4 million francs a month, or I mean a year. It went to 100,000 francs for a complete treatment. And as of last week, the minister signed a document saying hepatitis C is free to treat in Cameroon. So that's how you evolve in policy for a certain disease. So why not cancer? Because of course that still has to do with hepatic cancer, right? Liver cancer. So now I think a lot of these conversations are within the jurisdiction of the Minister of Public Health to handle. And sometimes I bet you it needs just advocacy and guidance, right? Sometimes it's not like these people just don't care or they don't want to do something. They might just not know how to do those things in a way that can work. And that's why we are all here. That's why we are getting expertise from all those who have contributed to the conversation today. That's why we are happy that we are a town hall that meets every 2 weeks. None of this kind of a platform in the entire Africa continent that I know that meets every fortnight to discuss on a particular subject matter, which is healthcare of a particular country, which is Cameroon, bringing together 2,300 healthcare professionals from about 36 countries. We might not meet all the time here, but if you look at the random numbers of people that gather here every fortnight, it's representative of the entire cohort of the Cameroon Town Hall for Healthcare Professionals. So I want to once more thank Dr. Munoh, our chair, for his leadership, for continuously steering the wheel of the ship for us to meet every fortnight, to bring all the experts that can do these presentations that we have, and for the excellent moderations of people like Brian, whom despite his busy schedule actually attending a very important conference is able to step out, you can see from his badge, just to do the town hall. That's how we feel about the town hall. We prioritize it on all of our Saturdays where we have the town hall to anything else, because it's important and because the fruits are there. We see it happening bit by bit, gradually, but it's happening. And I think that all of you who attend the town hall every fortnight, you are doing an amazing job just by attending, just by sharing and giving your contribution. You are doing a lot. And I think the future is very bright if we continue to put in this effort. Thank you very much, Brian, and back to you.
No, thanks a lot, Munoh. That's very kind of you. I would like to pass it over to Dr. Munoh, maybe for his closing remarks and his final comments. Dr. Munoh.
Yeah, Brian, sorry, I have a cough. What I want to say is this session was deliberately meant to be very provocative. And I usually don't do sessions like that because I wanted to provoke everyone who was participating to take this topic seriously. I am a solution-guided person, and I believe in solutions. So what is the way forward? The way forward is for us to advocate at every level for our government to be able to put in prevention strategies that we know that work. not only for breast cancers, but for all cancers that have proven strategies. There are not many of them. Cervical cancer is one, which our government is taking seriously. Children are getting vaccinated, and we need to increase access to vaccination. Women are getting pap smears. We need to increase access to that. We need to also increase access to mammograms. We need to educate the girl child and the woman to know, our mothers, that just being a woman is a risk factor. As we age, it's another risk factor. There are some genetic things that happen that we know about. There are some that we don't know. And the way forward in Cameroon is not going to be treatment. It's not going to be treating these patients with metastatic disease who will not survive, which, as I said, can be a lecture for more than 5 lectures, which I promised that I was going to give a series of lectures. I hope I can hold my promise before the end of October. This is going to be meant for physicians, medical students on how to manage breast cancer. It's going to be a series of 5 lectures showing you how breast cancer is complex, where I can help the doctors to understand what to do. Now, we should also remember that there are things we can do to reduce our risk of getting breast cancer. Most of the risk factors for breast cancer are non-modifiable, meaning we cannot change our genes, we cannot change our sex, no matter if we have surgery or not. We cannot change our age. We cannot change our genetic components, but we can actually breastfeed babies, which gynecologists here are going to agree with me. We can actually encourage women to start having children early when they get married. We can actually encourage people to lose weight and to eat healthy and to exercise. That is my message back home. We should not be afraid to talk. If we are surgeons or other specialists or oncologists and we are unable to have adequate practice, we should talk. We should advocate for change so that we can manage our patients better. So the goal of this was not to make anyone angry. Please, guys, don't. I'm always a solution person for Cameroon. I studied there. I know the brilliant people who are out there. The problem is never the physicians, never the nurses. The problem is the system that needs to be changed. We need situations and we need a healthcare system where people are obligated to also improve their knowledge. We need to pay doctors well. We need to pay the nurses well. We need to keep and retain workforce. If we don't do all of that, all the talking here is going to be useless. No matter how, if we train 1,000 doctors every year, 999 of them will move out of the country. So we'll still be left with 1,000 to train. So that's not going to be a solution. So thank you, Brian. I think it was I did not even go up to half of my presentation, but I think it was a very interesting talk that I had.
Oh, thanks, Munoh. It's always a pleasure to have you. I think I'll pass it over to Elvis, maybe to play the jingle to close the session. And always remember, we have a parking lot after every session where we just hang out.
So today the parking lot will be there for 30 minutes or more, even those who want to air out whatever they think is going on and for us to have a little background debate.
Thank you very much, ladies and gentlemen. It was a very interesting session. I want to thank all those who attended. I see Dr. Sostani Enoro, our interventional cardiologist attending, and all those who have attended. I see a lot of our regulars in the town hall. It's been a very interesting session. It's difficult to have Dr. Dieter attend from start to the end, despite his busy schedule. So I can imagine how this topic has been important to him. Dr. Fergus and all of you, you are the ones that make this town hall really amazing. Thank you, everybody. Thank you, Dr. Oku from Ivory Coast. It's been a great pleasure spending this moment with you, and we look forward to see you again in a fortnight, yet for another interesting topic of the Cameroon Town Hall. I wish you a very nice weekend.